Very good. So it being 10:01, I think we can start. Welcome to this morning's session of the Joint Standing Committee on Health and Human Services. This is neither a work session or a public hearing session. This is an informational session for committee members and other interested parties to hear from several different resources about various issues. Often with legislation, there's a report back that comes to the committee, and you'll hear several of those today. There's also some updates on some areas of particular interest, and Senator Moore will be presenting along those lines. So if you want to see the reports, the best way to find those is to go to legislature.maine.gov and click on committees, highlight the Health and Human Services Committee, and then go to reports or presentations. All of this should be there. It's all public information. So I think we can just start with introducing ourselves, and we'll start with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. I'm Sam Zager, honored to represent District 41, Portland.
Representative Lemelin.
Good morning, everyone. My name is Michael Lemelin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Westport Island, and part of South Bristol.
Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Callis, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Connor.
Thank you, Mr. Chair. Good morning, everyone. My name is John Connor, and I represent the good folks of part of Lewiston.
Representative Griffin.
Good morning, everyone. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Cadescate.
Representative Javner.
Morning, I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
And I should point out that Representative Javner has just rejoined the committee leadership structure, such as it is, and we're glad to have her back. And we want to publicly thank Representative Griffin for her able work in the interim. So welcome. Thank you both, and welcome. Representative Meyer.
Thank you, Mr. Chair. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton. I have the honor of representing the folks in Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. And this morning, we're ably assisted by Sam Sennett.
Sam Sennett. I'm an analyst with the Office of Policy and Legal Analysis.
And our committee clerk, Karen.
I'm Karen Thomas. I'm the clerk for the committee. If you need assistance, please email me, hhs@legislature.maine.gov. Thanks so much.
And we've been joined by Senator Moore. Welcome. We're not hearing you or seeing you, Senator Moore. Why don't we go ahead then and begin with briefings, unless there's other business to be taken care of first. Not seeing any. I know that we have some folks who are here to I think Dan Brennan should be, and I see that Eric Jorgensen is here. So welcome, we can bring him in. And then Brennan, if he's coming too. Oh, you're already in the room. I can't keep track of the different columns. Welcome, sir.
Good morning. Good morning.
Senator Moore, you want to introduce yourself?
Yes, thank you. Good morning. My computer decided this morning it needed to reboot for whatever reason. I guess it was too cold. So I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well. And I believe it was minus 20 degrees in Calais this morning.
Ooh.
Too cold. Too cold.
Well, your computer wanted to reboot and my snowblower didn't want to start. So not too hard to understand. So welcome the Honorable Eric Jorgensen also. Glad you could join us. And I will defer to you two to figure out who's going first and presenting this report.
Great. Well, I think I will just take it from here, Eric, if that works for you. So Senator Claxton and Representative Meyer, members of the Health and Human Services Committee, it's really nice to see you all today. I'm Dan Brennan. I'm the director at Maine Housing. Today, I'm going to talk to you about the Fuse Collaborative. And I am going to attempt to share my screen and pull up a PowerPoint here and see if this works for us. And are folks seeing that?
We are.
I see heads nodding, and I'll put it on the appropriate, there we go. Okay. So the Fuse Collaborative, this is a report back to you from work that you had authorized and directed us to undertake last year. And we have done so. We have submitted a report. The link to the report is here on this cover page. And why don't we just go ahead and get started. So this comes from LD 475, which is a resolve and essentially asked to create a collaborative to focus in on specifically 200 people in Maine that we know to provide stable housing and community services to them. These folks are homeless or they are at risk of homelessness. And the key thing here is they are the most frequent consumers of high cost services. So that's going to be a theme that we'll talk about throughout, but just think about those individuals that are the hardest to find housing for. They have tremendous challenges, and the committee recognized this and set us off to do some work over last summer and into the fall and come up with some ideas and thoughts that I'll be sharing with you today. This is the group. Don't intend to go through it all, but it was a wide variety of people around the state, from state government, from mental health services, from emergency health, advocates, just a wonderful group that got together. We met 4 times over the course of, I think it was September, October, November, and December. Had very robust conversations, and I will give a shout out to Lauren Bustard, our Senior Director of Homeless Initiatives here at Maine Housing, Representative Victoria Morales, and Cullen Ryan, who the 4 of us kind of formed the leadership team on this group and worked very well together to come up with the product that we're sharing with you today. So the frequent user system engagement. This is not something new. This is an approach that was developed by the Corporation for Supportive Housing. They're an organization that we have worked with over the past couple of years and engaged with them. They're sort of the national think tank and the national experts around homelessness issues, and we turn to them and have used their expertise. And this approach has been out there. And what's unique about this is it uses data about the population that we're targeting. The multi-stakeholder engagement, I can't stress enough. People need to be talking to people within a community around the issue of homelessness, and in particular, specific individuals that are really difficult to house. And this is all about supportive housing. And that is housing that many of you are familiar with, I'm sure, but a social service organization is directly involved with a client so that when they get housed, they stay housed. More about this target population. Again, frequent users of crisis systems. These are people who are coming in and out of our jails, people who are on the street, people who are in and out of emergency rooms and hospitals constantly. Obviously homeless, low income, mental health issues, physical health issues, and obviously the interaction with the emergency rooms and hospitals and law enforcement. Here's some data. We know that nearly 40 communities across the country have used Fuse. We're familiar with it. We understand it. We think that it's the right approach. 30% of resources are spent on 1% of the homeless population. That's staggering. But when you think of the cost of our correctional system, the cost of our emergency medical system, you get those numbers up there pretty high. And we know that if by employing these strategies that Fuse looks to employ, we can reduce that cost substantially, because we know that people do better when they have a place to sleep. When they have a place to sleep, when they're warm, when they get up and have a shower, a cup of coffee, they're better able to tackle their issues. So this is what we call permanent supportive housing, housing with supports that I've talked about, and it does result in stable housing and improves people's lives. And what this is going to do is this is going to help our law enforcement and our emergency medical personnel to be able to focus on the general public as a whole, rather than just a small group of individuals. I won't go through all the details in this, but this shows what data that has been obtained by Connecticut and Minnesota and Michigan, a significant cost savings, a very high retention rate in housing. So these, again, data-driven, following the individual, providing them supports, has a dramatic reduction in emergency room visits, interactions with law enforcement, and better overall for the communities that take on this approach. We have been working in Maine for several years, and one of the areas that we've seen particular effectiveness that's very common or very similar to what Fuse is all about is the Portland's Emergency Shelter Assessment Committee. And they've been together for almost 7 years now, and what they call a by name list effort. Literally, they have the names of each individual. They know who they are, they know them by face, they know them by name, and they know details about that individual's issues that have caused them to continue to struggle to find and stay in permanent housing. 16 organizations are working together on the Emergency Shelter Assessment Committee. I can't stress enough the importance of this. Not one organization has the ability to try and tackle this kind of a problem. As of last year, they have helped 355 individuals and 90% success rate of people staying stably housed. So we know this works. And what we need to do is we need to expand it. We need to focus in on those particular areas where it is most prevalent. Initially, I think the focus might be on Portland and Bangor and some of our urban centers, but the concepts here apply throughout the state. Some data that has been pulled together, there's the report itself will have a lot more detail, but the numbers that back up this comment here is all in the chart that's in that. Chart was a little busy for the slide. But just an 8-month period in 2021, Cumberland County, they know that individuals who stayed unhoused were over 20 times more likely to be in jail or 7 times more likely to be hospitalized than someone who found stable housing. So the data is just really strong here. These are the cost savings that have been calculated. This will show that a cost per day for someone in jail, $900. Going to the emergency rooms, $1,000. Riverview, $3,000. But when you talk about permanent supportive housing, $33 versus an emergency shelter, which is $40. So the cost of housing and providing services to someone saves this kind of money. It's the right thing to do. So there are some challenges out there that the committee identified that we know. One of them, we're very busy here at Maine Housing on the lack of adequate housing supply. There just aren't enough rental units. There aren't enough single family homes. We know it. Luckily, you as a legislature, governor, our congressional delegation have been very generous to us and have entrusted us with millions of dollars to help address this issue. We have the largest pipeline of multifamily units in our history right now. Last year, we put over 500 units online, completed, again, another record. We're just going to keep that momentum going. So I appreciate your support on all of those things that have happened over the last few years, but the job isn't done. We need more. We need to continue to help find available housing units that are out there and landlords that are willing to help these individuals out. They are not, it's a different challenge. And by working directly with landlords and who have available units, a lot of effort has gone into that, housing navigation efforts and other things to help make that connection. We know that over time there has not been enough money for services or treatment or supports. We know that you share that concern as well, and so the more that we can continue to focus in, we can become more efficient. We've got a great relationship with our friends at DHS. We meet with them every other week and go in depth on issues, and so we're working to be more efficient. We always need more money. And these folks that we're trying to help are the hardest to engage. They're the hardest to get to focus in on trying to receive the help that's being offered, and continued efforts to make sure that those folks take us up on the offer that we can help them out is an ongoing challenge. But Fuse has several opportunities, right? The collaboration, state agencies working with service providers. And this just isn't Maine Housing and DHS. I mean, this is corrections and education and labor, and all of those groups are talking, but also within a community, all of the different service providers and the nonprofit organizations and the schools and the hospitals and everybody collaborating together around trying to help solve this problem. We do have some federal funds coming in, specifically under the American Rescue Plan. We've got some federal home funds that are coming through HUD, $16 million that's coming here to Maine Housing. And we're going to be rolling that out shortly, providing capital funding for the acquisition and rehab, or even new construction of supportive housing facilities. We've heard the concepts of other states where small hotels or motels are being converted into permanent housing. There might be some opportunities there, but we don't have to restrict it just to those types of buildings. But we're going to look to deploy that $16 million as soon as we get the paperwork from HUD out of the way. Our friends at DHS have done a tremendous job in putting together the homeless health program. I am not a Maine Care expert, but I appreciate the focus that Beth Ham and Jessica Pollard and their teams have done on providing a resource to the service providers to help provide the services that are needed. And we really appreciate that. There's a long-term stayer initiative in Portland that has already, I think I talked a little bit about that already, these folks in Portland know how to do this. And they've been working at it in Bangor too. So, and then finally, on a bigger system-wide thing, our Maine's homeless response system is being redesigned. We're using a concept called Built for Zero with a group called Community Solutions. They have worked in other states. They have been working with us for the last several months. We have redesigned the homeless response system into 9 service hubs. Hub coordinators are currently being hired. Maine Housing is funding that, and really trying to help communities in Maine focus on homelessness as a regional issue. So that is underway. So some of the recommendations in the report, these are very high level. And again, I encourage you to read the report and look all that's in there. But the first goal is to focus in on these 200 individuals and find my camera here is, there we go. I'm sorry. By December of 2026, we want to get these individuals housed. So we've got 3 objectives, looking at a variety of housing and subsidy models. Not just one model is going to work here. We want to create 150 new permanent supportive housing units by December of 2026. And in the meantime, we want to identify short to medium term bridges to permanent supportive housing. So these are less formal approaches, but ways to just get the job done. And we're going to focus in on what we can do in the short term while we're looking at more long-term solutions. And the second goal that the report outlines is to ensure that the long-term support services are in place by December of 2023. We need to ensure that these funding mechanisms are uninterrupted and that they're always constantly available. And then make sure that we focus in on trying to work with these individuals, that we need to build trust. And that's much of what is the barrier. Is these individuals don't trust systems, they don't trust service providers, and they revert to what they know, which sometimes is putting them in harm's way. So there is an implementation plan that the report talks about. There are 2 phases. The first one is in the first 3 years, talking about how to incorporate all of these FUSE activities into the homeless response system. So this effort with FUSE is going to become part of and integrated with the new homeless system redesign. So coordinating efforts, establishing the data and the dashboards and the reporting tools that are vital, developing these various models. We know that we feel quite confident that we can do at least 30 units a year. Do that over 5 years, you have your 150 units. And then try to ensure low barrier access and continuity of wraparound support services. And that's the most challenging part, the low barrier piece, because sometimes people, when they do engage, they're still not in a good place. And sometimes their behaviors prevent them from receiving the services. So we got to work on ways to deal with that. And the second phase is in the last couple of years of this 5-year period, continuing the development and getting, that's never going to stop. That's always going to be part of what we do here at Maine Housing and working with DHS to find those services. But then that'll give us an opportunity to see what we've done, evaluate it, and tweak where we need to and adjust. And that's usually the best way to get something, put it on the street, and start accomplishing things, and then refine it as you go along. And then by then we should be able to do a fairly comprehensive, cost-effective study. Again, just to continue to make the case that this is the right thing to do, and funding should flow to these efforts. There are 2 pieces of suggested legislation that folks are working on. One is a bill that's going to provide ongoing funding for the development operations of a model very similar to what we've been doing with recovery residences. We have been, with the help of your committee, we have been using funds from DHS to provide operating assistance to recovery residences so that individuals who are going through that can receive services in a recovery residences when they don't have any income, they don't have any money to contribute towards it. And then secondly, a bill that is going to ask to create and fund 10 to 12 case managers within DHS to work directly with this population. So again, this is a strong partnership here between us at Maine Housing, folks at DHS, and everyone else on that committee that helped us out. So that, in a nutshell, is the FUSE collaborative work and the efforts. And I will do my best to answer whatever questions that you may have. I'll stop sharing my screen now. And I'm not a subject matter expert in some of the things you all might be, but I will do my best. And what I can't answer, we'll make sure that we do get questions and get your answers back to you. So with that, Senator, I will turn it back to you.
Thank you for that presentation. I see a number of questions already. We'll start with Representative Perry.
Thank you. I actually have a couple of questions, and I guess the first question is, with this program coming out, are you looking at the whole state or certain areas you're going to address first? Looking at other areas? How do you plan to do that?
Yeah, I think initially the committee talked about wanting to focus in on Bangor and Portland initially. That's not to the exclusion of other areas of the state, but we know that right now Portland and Bangor are having such difficulties. And I put in Lewiston there as well. I mean, our service centers, right? But the committee felt strongly that some early strong success can be achieved in those two areas. But we also know that rural Maine, we can't forget about rural Maine. And so I know that that's kind of a squishy way to answer that, but Bangor and Portland jump right out. What's happening is people are going from the rural areas to Portland and they're going to Bangor. And part of the regional service hub approach is let's try and help people within our own communities first before they travel to another community.
Thank you. The second question is because we are now looking at a significant increase in cost of housing. And that goes both with rural and urban areas, as there's been quite an influx, probably because of COVID, because we're also seeing that in our area. I will say that in rural areas, there's a lot of hidden poor and hidden homeless, which I've been able to see. We've also said you're working with HUD because our area lost HUD housing and we had a really, really tough time finding housing for people to even be able to maintain the work at the jobs that they had because they didn't have transportation. And I don't know if you deal with that or if that's something Fuse in the future would look at in terms of some of those issues.
Well, I can tell you that the loss of HUD housing concerns me deeply. We are involved, Maine Housing is involved in a whole array of housing issues. So if Fuse is not the exact place where those issues or concerns lie, we do here at Maine Housing get involved in quite a bit. We're very involved in financing, developing more units. Yesterday, we announced with the governor's help, a single family approach to build single family starter homes that aren't being built anymore, multifamily development, supportive housing development. And then wherever federal resources are, we're involved. So I appreciate those comments, Representative.
Representative Zager.
Thank you, Mr. Chair. Well, first, I want to extend a special welcome to Honorable Eric Jorgensen, who actually preceded me. So I appreciate the expertise that you and Mr. Brennan are bringing. I also want to express that I'm very excited about this effort. It's evidence-based and it has tremendous potential. But I know that it's also complicated and even good ideas need to be calibrated well. My question, I guess it fits a little bit with what you were just answering for Representative Perry, but one of the recommendations was to develop various models for housing the Fuse population. Anything else you would add on what you mean by that?
Sure, I appreciate the question, and selfishly speaking, we're thrilled to have Eric Jorgensen on our team now. You know, some individuals will not succeed in a 24-unit apartment building. They need a smaller setting. They might need a duplex or maybe their own single-family home or another setting that looks different than what might, so in some cases they might need medical care for a while. So we have to recognize that the folks that are going to be focused, the folks that are going to be served by this Fuse effort, it's not as simple as just finding them an available unit. It has to be the right unit. It has to be the right landlord. It has to be the right service provider with them. Many of these individuals are very ill and need that level of attention to get healthy. So I appreciate the question because just finding a unit, which is hard enough, isn't necessarily always the right answer to have a successful housing finding housing that succeeds and people stay there. So there've got to be alternative ways to look at things. Smaller units, they might be an accessory dwelling unit, a number of different things that we look at, and not just your traditional apartment or single family.
Thank you.
Representative Stover.
Thank you, Dan, and thank you to Eric. I just wanted to echo what Representative Perry said. I live in Lincoln County, where there's no viable alternative to, there's no homeless shelter readily available in any direction. And there really is no housing. And the bubble burst on the housing market here quite a while ago, and an average home that sold for $250,000 2 years ago now sells for $450 to $500. And there's absolutely zero rental. And I work for a small nonprofit. We run 8 programs that basically take care of the people that live here on this peninsula. And I can tell you, we found 1 hotel room last week on the peninsula for 2 people who were living in a camper until last week. They stood it, they made it that far. So it's every day. We're finding people who are staying in places that really aren't fit. We have a man living in a van. They're not traveling anywhere because there's no place to travel to. So I'm really excited to see that there are going to be some options, and that some of those options might be available to rural places, whether it's Washington County or Lincoln County. There's still a rural nature to living at the end of a peninsula, which is essentially an island with a bridge most days. So thank you for listening again to my plea for the needs of Lincoln County.
Yeah, I appreciate that, Representative. Remember, the Fuse effort that I'm talking to you about today is a narrow focused issue, but it is part of a larger effort that we are currently working on as well, which is the homeless system redesign, which has identified 9 hubs, including all counties of the state. So activity is occurring throughout the state, and Fuse just layers into that. So I'm excited as well. I've been doing this a long time, and I have not experienced the level of support and encouragement from not only folks like yourself and the state legislature, the governor's office, the federal government. You all understand the issues we're facing, and you're supporting it. So we're humbled by that, and we know the responsibility is great, and we're looking forward to moving this in a whole different direction for the next generation.
And thank you. And I understand that Fuse is what it is, but there's some of the other 16 million. I can think of 16 million other things that could be done, perhaps with some of that other money. And we actually have philanthropists down here willing to pitch in and match. So hopefully something will come to us. Thank you.
That's wonderful. Absolutely.
Are there other questions of from the committee? If not, I had a couple. One of the relative advantages for Portland is the geographic concentration of support services. Have you all identified which of the 16 organizations, or what are the minimum standards that would give somebody a chance to be successful in new housing? As opposed to some of the others? What are the key wraparound services as you've identified so far?
That's a little bit out of my expertise, Senator. I'm sorry. What I do know is that in every area of the state, yes, there is concentration without a doubt in Portland and in Bangor. That there's a lot of concentration of social services, and what each one of those organizations does, I just can't speak well to that. Because organizations specialize in different things. But what's important is the approach, that's the regional approach, is making sure that all those organizations are talking to one another and communicating with one another. Because, I always enjoy getting together with someone who does something a little better than I do, and I'm not really good at that particular thing, but you might be. And there's a lot of synergy and collaboration that in some cases already has been established. But the more we reinforce that, there are current services and systems in each region of the state that I think can be enhanced and work more closely together. And that's what we're trying to encourage.
Great, thank you. And my other question, just to be clear, you said there were two pieces of legislation that the committee had come up with. Do I understand that those are both actively being worked on and that you don't need help from this committee right now?
I would not, I would imagine they are both being actively worked on, but in terms of we don't get too involved with legislation here, the crafting up of it, more of a subject matter expert to that particular. I do know obviously Representative Morales is very passionate and active. So I might refer that question over to her in terms of exactly where that sits, right?
Because one of the options we have would be to introduce new legislation if the committee felt strongly we should be doing something in addition to what's being done now. So I just want to check about that. Representative Javner?
Thank you very much, Mr. Chair. I just have a logistical question, really. I'm really curious about the demographics of the homeless. Have you guys, did you look at that versus like families with kids, single people? What is it that we're really looking at here across the state?
Yeah, we do. I can't recall, couldn't articulate them off the top of my head, but we do have demographics around the homeless population. Every individual that interacts with the homeless system has a record and data. There's a lot of data reporting that goes along, including demographics. So we have numbers and we can share those with the committee, what we know. We do know that homelessness disproportionately affects people of color. We know that. And that's just not acceptable. But we do have good data. We'll be happy to share what we have with you. And then if that doesn't fit what we're looking for, we can continue to work with you to get you what you need.
Thank you.
So what are next steps from here? Have the 200 people been identified? Is the team been working on planning? What's it going to look like when you come back and tell us about how it's going 6 months from now?
Yeah, one of the things a lot of times, as you might expect, at the end of a legislative session, there's a lot of reports, there's a lot of committees formed, and there's a lot of data gathered, and it kind of you get to the end, you'd submit the report, and the committee has done its work. This one, I think, is one that's gonna have lasting power. And within the statewide homeless council and the new approach that's being taken, this fuse effort in the individuals that worked on that are going to continue moving forward. As far as moving forward right now, some of these initiatives, some of these things are already in play and have been in place. So the Portland approach and what they've been doing in Bangor. I think the most immediate next step is where the legislation sits and funding requests, and then seeing how that integrates in each of the 9 service hubs. Those 9 service hubs have been created. As I mentioned, they're each going to have a hub coordinator. Maine Housing is going to fund that. We're in the process of doing that right now. And then once those individuals are established, my expectation is that each one of those 9 hubs and that hub coordinator would have a fuse approach figured out or planned. So we'll see how it goes. These system type changes are not done overnight. It took about a year to kind of come up with the framework. And now we're in the second year of the first year of implementation. So I'd be happy to come back in 6 months or when you're back together again and give another report on where it is, or allow the leaders of those efforts to do the same.
Given the importance of housing in so many levels, mental health, physical health, workforce, all of those issues, I do think the committee and in general, there's a heightened awareness and a need to get regular follow-up. So we could make this part of our annual orientation step, a report from you all. And the other point I thought about was that it's not as if Fuse is doing this as an experiment in a vacuum. What you're learning and trying to codify is going to be shared to all the hubs and from the hubs to the communities. And so there's a spread that's going to happen, even though you may not be dealing with the more than 200 people.
Yeah, absolutely. We learned this week, we had a case where an individual, a city manager, reported in that one individual had kind of bounced around from community to community. And each time they landed in a community, the other community just sent it to another community. They might have thought they were doing the right thing, but it happens too much. Wherever an individual is that's homeless, that community should rally around that individual so that that individual can stay in their community, be part of their community, and unless of course it's not safe for them. But too much of the bouncing around, and hopefully we can continue to work at ways to alleviate that.
Thank you. Representative Javner?
Thank you, Senator Claxton. So going back to the funding piece, you mentioned an amount from the ARPA funds that are going to be utilized for these services. I'm really curious because we all know that is that fund that you are talking about for ARPA funds, is that the direct ARPA funds from the state, or is that from the county level? We all know that each level receive different amounts. So I'm really curious about counties individually, how they are going to be putting, if they're going to be utilizing some of their ARPA funds as well for housing, or if the amount you mentioned is what the state received as a whole.
Yeah, so there's so many pots that came into the state. The $16 million came from the American Rescue Plan, and it went into a HUD program they call the Federal Home Program. And Maine Housing is what's called a participating jurisdiction. We administer that federal home fund. So we are receiving directly $16 million from HUD, and we're going to deploy it. We've been through a whole public process of intake and information gathering, and we're about to launch that $16 million pot. I've also had the opportunity over the past several months and even in the last week to address the Maine Municipal Association and 200 municipal leaders around the state. And we're encouraging those municipalities to use their ARPA funds that they're getting in housing. And we can talk to them about how to do it. They don't have to recreate the wheel. We've got the system all set up. So it's very likely that, and hopeful, that maybe some of those funds from counties and municipalities can find their way into supporting FUSE efforts and the homeless effort. We've done quite a bit of outreach with community leaders to encourage them to really think about investing in housing. And in some cases, our phone starts ringing off the hook with people wanting to do it anyway.
Are there other questions? We should give the Honorable Eric Jorgensen a chance to say something if he wanted to. It'd be unusual to not hear from him.
Thank you very much. Well, I was hoping Dan would make this presentation because he was part of he was on the committee and did all the work with the committee. I wasn't. And as you can see, it's great I think it's really great having the top person in our agency personally invested in this particular project. I think it's a very exciting one. And I just would say that I'm around if people need if you have further questions. I've got Representative Javner's question about the demographics of homelessness in Maine. We can certainly provide that. And certainly if there's other questions that come up or there's other things you need from Maine Housing, I'm your man. So I look forward to continuing to work with you, and thanks again for inviting us.
Thank you all for being here and bringing this information. Fingers crossed, and good luck in the next 6 and 12 and 5 years.
Nice to see you all. Thank you so much.
So next, we're going to hear from a couple of our own about something that they wanted to share related to the Mental Health Summit. So I'm going to defer to Senator Moore and Representative Gramlich. Welcome.
Thank you very much, Senator Claxton. I really appreciate that. And we are anxious to share a little bit about the Mental Health Summit itself. So I'm going to share my screen. We've got a few slides here that Representative Gramlich and myself will be working through to share some information about the event. So let me do that. There, can everyone see that okay?
We can.
Yeah, great. Well, the Mental Health Summit actually highlighted our current and our crisis of lack of care in Maine. So as I attended the event on November the 30th of 2021 at the Augusta Civic Center. It was very, very nice. We were in person and everyone walked around saying, "Oh my gosh, it's so good to see you. It's so good to be in person and to be able to talk directly with you with our masks on, but still we were there." So Representative Graham, would you like to introduce yourself as well, please?
Thank you, Senator Moore, and thank you, Senator Claxton and Representative Meyer, my esteemed colleagues. Really honored to be here to have this opportunity to give a virtual face-to-face overview of what transpired from our mental health summit. And just by way of background, the impetus around kind of coordinating and organizing this, as you are all well aware, we are beyond crisis levels in our mental health system in the state of Maine. And the summit was an opportunity to begin to have a really deliberate conversation with stakeholders and vested parties about how we can collectively come together to comprehensively address the issue. We had about 78 people in person attending. We had approximately 135 watching virtually. And you all have received an email from me this past Monday that had some high-level overview, and it also had attached the video. It's a 5-hour video, but we were able to provide indexing so that you can hone in on particular components of the summit. We had consumers of services, providers, family members, and legislators all on various panels. So that I just wanted to provide you with the framework to set the stage for our discussion this morning.
Great, thank you, Representative Bramlett. So moving on to our next slide here. What we did at the very beginning is we just really brainstormed and really looked at and highlighted our current crisis just to give us a good basis to where we were. We found that there were only 87 mental health crisis workers for the entire state, compared to more than 2,500 law enforcement officers. So what it's leading to is the saturated involvement of the criminal justice instead of the healthcare system itself. As of November the 20th of 2021, over 2,300 people wait for openings for outpatient mental health treatment. Maine Health reported that 32 out of the 45 emergency department beds are filled with individuals waiting for discharge for residential mental health care. We had a kind of a conversation the other night on one of our bills. And one mother shared with us that her son had been in the emergency room for 32 days waiting for a bed. It was just heartbreaking to hear that. And currently there's more than 70 children are in out-of-state treatment centers due to the lack of capacity in Maine-based organizations. When we looked over the other sides of it, there's 260 residential treatment beds for the children that do remain empty due to the lack of staffing. Again, we're all into that whole problem of the lack of our workforce and the lack of staffing that is causing some major holes in where we need to be providing some treatment. Again, children are experiencing a psychiatric crisis, languish for days and sometimes weeks in beds in hospital emergency department hallways, waiting for placement options. I know that there was one young man that was in the hospital there in Machias, and he would try to get out of his room and he would wander in the emergency room and they would be performing CPR and he's asking the nurse for a sandwich. It just wasn't a very, very good situation. Our local county jails have become the holding tanks for adults experiencing a mental health crisis, leading further decompensation for many of them. It's almost becoming the mental health facility, and really it should not be that. It should be more for our to be able to handle the situations that are involved with the jail itself. And in the past year, over 20 mental health residential programs, those are those private non-medical institutions, the PNMIs that Anna loves that word, in Maine have closed due to deficits in their finances and consequently the lack of staffing to go with that. When we talk about mental health and we talk about behavioral health, we know that they go hand in hand with our substance use disorders that we are experiencing throughout the state. So one of the crises that came up with, in lots of conversation, was the fact that 12 or more Mainers die each week due to opioid overdoses. And we've been hearing a lot about that in some of our briefings with Gordon Smith and the opioid program itself.
So everything that Senator Moore identified were the high level topics that we covered at the summit. But it's worth reiterating that Maine most certainly lacks a functional behavioral healthcare system. We do not have an adequate strategic plan for our behavioral healthcare system. Maine lacks access to consistent quality behavioral health treatment and social services. And we're not alone. Given that the American Academy on Pediatricians have announced a state of emergency, literally a state of emergency for children's behavioral health services in the United States of America.
So go ahead.
That's okay. Senator Moore and I we're going to tag team a lot of this, so won't go too deeply into this. This is just for your reference. These are some links to some of the coverage that we realized after our summit. And again, some of these were also embedded into the email that I had sent to members on Monday, the 24th. I'll just note, these are recent news stories. I'm able to go back 5-6 years with news stories that could have been written yesterday. I was doing some research on a particular bill, and I found an interview that I had done when I was an advocate in 2017 addressing these very issues. Sadly, this is not really anything new. So we were able to identify a number of solutions discussed at the summit. These solutions they are all direct feedback from participants of the summit. They are folks that are in the system dealing with the reality of our fractured mental health system in terms of consumers, professionals, and direct care workers. So this is really unedited feedback that we had received at the end of our summit as a result of what we had discussed during those 5 hours. So accessing federal funds in terms of adjusting reimbursement rates will indeed provide additional funds that will directly impact our workforce. Let me just see here. Cross-sector collaboration between health systems, law enforcement, and community-based services to increase diversion from incarceration or criminal justice involvement is critical. As Senator Moore identified, often there are some dual diagnoses in terms of folks struggling with mental health issues, as well as folks struggling with substance use disorder. And quite sadly, often law enforcement gets involved with these populations, and these individuals end up in our criminal justice system, and that is not the right and appropriate placement for these folks. Expanding opportunities for residential treatment, outpatient therapy, and community-based mental health does not come without a cost. We've heard about this over and over again. I know you folks all have in your committee over and over again. However, these prevention-based initiatives will ultimately save the state money. Critically important is to involve people with lived experience in these systems. And equally important is to have all stakeholders and vested parties at the table to collaborate at the state level so we can address this issue in a comprehensive way. Again, I want to underscore that this feedback comes directly from the participants at the summit. Given that, we need to assure that our correctional, again, as I said earlier, we need to assure that our correctional institutions are not mental health facilities. In fact, we had a couple of county sheriffs and different representatives from law enforcement at the summit. And one sheriff in particular said something to the effect that jails in his particular county was his biggest mental health facility in the county. And in my opinion, that's unconscionable. Certainly, we know that data drives best practice and accountability, so that's really important, and participants noted that. And finally, people who are unhoused have more significant challenges with accessing mental health treatment.
That conversation we just had with the housing department showed us exactly that situation. And what you mentioned, Senator Claxton, by providing the housing, but also support services nearby, I think is so critical. And we heard that over and over again from a lot of the attendees that are living it, are going through the entire situation itself.
And I'll add to that in terms of how to kind of foresee or quarterback that is where we get case managers and targeted case management, because those folks are equipped to have a keen understanding of what the resources are in any given community and help consumers, clients, patients, whatever terminology you want to use, help these folks navigate these systems and access these services.
So we did want to bring to your attention a handful of bills that are currently sitting on the special appropriations table. I will remind most of my colleagues that most, if not all of these, were passed out of our committee, either with unanimous or strong bipartisan support. So we have this slide provided to you just for reference purposes. I'm not going to spend the time going through it. We are in hopes that some of these will be funded in the governor's supplemental budget. Some have been funded in the previous supplemental budget. So we're hoping that we will continue to place the emphasis on our mental health situation, our behavioral health situation, and our substance use disorder situation throughout the state of Maine. So there's this page, and then this page continues on to that.
And I believe, correct me if I'm mistaken, Senator Moore, I believe that this PowerPoint has been sent to all of the committee members. Or will be.
It will be. It will be sent to all the committee members.
So you all will be able to reference this, but I'm gonna reiterate and underscore that these bills, I can tell you firsthand that you could just change the date. We could go back 10, 15 years, and you would see very similar bill titles with certainly different fiscal notes because 10 or 15 years ago it might not have cost as much. However, this is nothing new. What I will say new is that we are beyond crisis levels to address this situation. And unfortunately, COVID has exacerbated it. Families don't know where to go. Children are languishing in emergency departments, which is heartbreaking. Children are placed out of state without their families. You have a college student who graduates with her bachelor's degree in social work or her master's degree in social work, and they can't afford to work in the state of Maine because we're paying them $12 an hour. And the reason we're paying them $12 an hour is because providers are not making enough money to pay their workers. So, looking at this issue from a comprehensive perspective in terms of all the issues we've identified, and certainly as a workforce issue as it is, with all the vested stakeholders at the table, I think is going to be a critical first step in advancing these initiatives. There are a number of bills that will come before various committees this session. They've either are in iterations within the committees of jurisdiction or will be coming soon to a committee near you. So I just wanted to give you an opportunity to just kind of see what's coming down the pike. I will identify one that I'm a little bit more intimately familiar with, which is LD 1910. When I get done with you folks, I'm going to pop over to the Health Insurance Committee and provide some testimony on that. Currently, evidence-based practice is not reimbursable by private insurance. So these practices like targeted case management that we talked about, or family functional therapy and other peer-reviewed evidence-based modalities that help families and help children in crisis, aren't covered with private insurance. Imagine if you needed antibiotics and you knew it worked, but you were told, sorry, we're not going to pay for that for you. So Representative Tepler has a bill in that hopefully aims to address that. And you can see there's a few more that will be coming before you.
So that kind of summarizes the summit that we had there in November. And we just wanted to share this information because I know we've been talking about behavioral health, we've been talking about mental health, we've been talking about substance use disorder. And so we thought we would share this information. It was a well-attended, well worth the 5 hours time, spending it being here in Augusta and talking about this critical crisis that we're undergoing here in the state of Maine. So I'm going to open it up for questions. I'll stop sharing my screen.
And quickly, Senator Moore, I just want to also just kind of reiterate, the summit was the beginning of a conversation.
Absolutely.
This opportunity today is the continuation of the conversation.
Absolutely. So we'll take any questions and attempt to answer them the best that we can.
Representative Perry.
Thank you. This is sort of a general question. There was a period of time when Maine Care paid for licensed psychological counselors. And that was removed at one point. And I had patients who were working with psychological counselors who literally lost their opportunity for counseling at all because there were not enough in the area to be able to have them transfer to someone else. Is there any discussion, I don't care who answers it or if there is an answer that we can give to the department about reinstating that? I'm honestly thinking of introducing a bill to do that because that offers options for more people to work within the mental health system who really need it, who are not being served because this part is being left out.
You want me to try to take that one, Senator Moore?
Yes, please. You have way more experience in that field than I do.
Thanks, Representative Perry. I know that you have a long history in this field, and I believe the population that the licensed folks that you're referring to are LCPCs, licensed clinical professional clinicians, or something along that line of that iteration. And I do have familiarity with what you're referring to, although I'm not entirely certain how or why that piece was removed. It certainly is worthy of a conversation. I am not aware of anything pending in terms of reinstating that. And again, I want to make sure that I have a better understanding of why it was removed in the first place, because I know there was a point in time where it was included, but that is, again, my opinion, another valuable tool in our toolbox, because the idea is we really want to expand services to as many folks as possible. And I'm speaking as a social worker, and I'm talking, I'm always going to advocate for my profession, but beyond that, I'm advocating for the people that have needs that are not met. And that really is the critical point that I think we need to keep in front of us.
I think I'm going to give you a little history on that because I was in the legislature when it was in before. And from my understanding, it is by federal rule that LCPCs are not paid by Medicaid. And when the state had it, it was purely out of state funds. And I think that's the reason it, budget-wise or something, that it got removed. But I think it has done more harm than having saved money. And I think that's just something we need to consider.
Thank you.
Representative Craven.
Thank you, Mr. Chair, and thank you both for the presentation. It was really great. But we, here in Lewiston, talking to law enforcement, we have a catch-22, especially for people with substance use disorder, being arrested, brought over to the jail, released, and the cycle keeps going around. So I was wondering if there was any conversation in the conference about, how to break that cycle and where are law enforcement supposed to be referring people who need mental health services or substance use services. It just seems like it's a constant problem without any solution. So I was wondering if there was any conversation about that in the conference.
Thank you, Representative Craven, for the question. And there was a lot of conversation about that. And bottom line is the lack of availability of beds, of residential beds, and these folks that are needing mental health, and the beds are not there. And so that was the conversation about the coordination, the collaboration between all groups, to try to see if we could find those beds, find those housing availability, the stability that's needed to keep them out of prison, which is so important as well.
Yeah, thanks. I think the other piece to that too, because there was quite a bit of dialogue around the intersection of the criminal justice system relative to mental health, behavioral health care, and substance use disorder. And one of the things that has become painfully apparent is that more often than not, our law enforcement officers are expected to intervene in situations that are increasingly challenging, have increased social implications. They're responding to dangerous situations relative to domestic violence. They are interfacing with folks with chronic persistent mental health issues. And respectfully to law enforcement, they don't always have the skill set and training to adequately interface with these populations. I actually have a bill in the Criminal Justice Committee that would expand their training. I can tell you in my own community in Old Orchard Beach, I just learned that the town has hired a social worker to be part of the police department team and staff. And I think the city of Portland has done, maybe Representative Zager might speak to some of this or might be familiar at least with it. But my understanding is that the city of Portland has also begun to take steps to engage mental health professionals to be embedded into law enforcement.
Well, not to interrupt, but we actually have one here in Lewiston, but at the same time, if they don't have somewhere to refer a person needing care, then they're just writing kind of, it's just.
I agree. And what I was going to say, Representative Craven, was that's just but one step. We have to look at it in a comprehensive way, because you're absolutely right. If we've got these folks on the front line providing the intervention and the services in the crisis, it doesn't really do us any good if there's no place for the folks to go to get the treatment they need.
And I will add that Representative Gramlich will be presenting to the Criminal Justice Committee tomorrow. So about the summit to bring them up to the same level of understanding of the situation itself.
Yeah, we'll be in Representative Talbot Ross and I will be in the Criminal Justice and Public Safety Committee tomorrow, and we're going to hone in with a lot more specificity around this very issue. And I can forward that slide deck to this committee as well.
Representative Zager.
Thank you, Mr. Chair. Just to offer a thought on what you were just last talking about, Representative Gramlich, is I think this is all very important and exciting work, and it does seem to me that even in the absence of a place to refer people to, or that full infrastructure, some sort of shift so that in our staffing with on patrols, if you will, and also in police departments, so that we can not criminalize mental health crises, might still be a benefit, knowing that it's not the panacea, but I think there's a lot of work to do, and I think one of the first two slides reflected that tremendous imbalance in how we've set up these systems. So thank you for highlighting these.
Thank you, Representative Zager, and I agree with you completely.
I don't see any other questions. I'll just offer an example at a micro level. I got a phone call yesterday from somebody who lives 75 miles from here, who's been trying for 5 months to get a foster child the services they need for trauma-informed care, and haven't been able to. And somehow they were referred to me. So that goes along with that 2,300 figure of folks waiting for mental health. That's an astounding number.
Well, in rural communities, pardon me, Senator Claxton, as you are probably all well aware, rural communities are particularly adversely impacted by this. And your colleague, Representative Madigan, has a bill on the AFA table that aims to address some of that on LD 582, which will provide for greater accessibility for ACT teams, which is critically important. But again, if we don't have the workers to reach the population, we're trying to operate with one hand tied behind our back.
Representative Stover.
Since we bring up rural Maine, I have some data from a colleague of mine who works as a consultant for 6 northern hospitals, including St. Joseph's, Northern Maine Medical Center, Millinocket Regional Hospital, Mount Desert Hospital, Holton Regional Hospital, and Curie Medical Center. And for the period of September 1st, 2020 to September 30th of 21, so the year prior, just September to September, there were 332 individuals that waited days in placement awaiting placement were 3,617. 332 people waited 3,617 days in emergency rooms in northern Maine to find mental health services. And the average length of stay for those 332 people were 11 days. And that's during a period when we already know that our healthcare system was overstressed from COVID. And we often forget in the lower part of the state that up there where there are fewer resources and they're far between in terms of driving distance, how that can exacerbate an already stressed system. So I just want to share that piece of data. Thank you.
Absolutely. Thank you.
So did I just freeze or did Representative Stover?
No, you froze.
She's back. I'm back. Okay.
Okay, good.
I forgot to mention the mandatory technical glitches throughout our day. Did we hear anybody during that conference? Was there any conversation about recovering some of those counselors' resources from other jobs to staff the positions? If we doubled the pay, are there people out there who would come back to that work? Or are we really in a big hole that's going to take years of training to fill, or some combination?
I think it's a mix of all of the above. Senator, to be perfectly honest with you, I can tell you anecdotally from the other hat I wear, which is adjunct faculty and field coordinator at the University of Southern Maine School of Social Work. We are graduating social workers every year, and lots of them. And that's just at USM. We have 5 schools of social work throughout the state of Maine that are graduating social workers who become licensed and aim to work in the field. Quite often, they begin that journey and realize that they can't sustain their living on $12 or $14 an hour. So I think it's a combination of everything that you've described, but I do believe that we have workers that go to school to do this work, but they just can't do it in Maine because they can't afford to.
And if they had affordable childcare, it'd be easier. And if they had affordable housing, they wouldn't have to. Exactly. It's
everything.
And help with their student loans too, probably.
Oh, yeah, and we've done some work about that, but not enough. Yeah. Representative Stover?
I can say from working in this area of the state, we can't recruit people for positions, not just because of the pay, but there's no place to live. And there is
That's the housing. Yeah.
So for instance, I have a social worker who works for me and she travels from Bath. She doesn't live here. She lives 30 miles away, which is fine. That's 30 miles is nothing for us, but the reality is there's no place to live. And if you can live here and afford it, because even a studio is $1,200 a month. If you can live here and afford it, childcare is about $175 a week. So if you start taking a social worker salary and then start dividing it up like that, there's very little left. So it's really hard to recruit and retain people when they just they can't afford a place to live if they could even find one. It's a complex problem.
Yes, Reverend Stover, and I think on one of the earlier slides when we talked about solutions, this is not there won't be a single pronged approach that's going to address this. We need all vested parties at the table. We need all stakeholders at the table, including folks that are working on housing and affordable housing and homelessness. I mean, in my opinion, mental health intersects so many of these areas. And if we are going to try to support, in terms of the clients, if we are going to try to support folks in their recovery, they have to have a place to live. They're not going to be able to get well if they're unhoused. And if we're going to have workers that are going to respond to these folks, they too need a place that they can afford to live in. And so the housing issue, and I know we've got colleagues that are tirelessly working. I know Representative Morales has been a real leader in addressing this, as well as many of our other colleagues. That's one piece of it. But for me, it's like pieces of a puzzle that we're all going to try to put together. We're not going to be able to have that puzzle complete unless all of those pieces are there on the table to put into place.
Okay, thank you for all of that. be nice to walk away from one of these conversations feeling like it'll get straightened out soon, but this is a long-term process.
Right.
Okay, so I
Thank
think at this point, we'll thank Representative Gramlich for joining us, and we'll go back to the next. Is your hand still up, Representative Stover, or? No, okay. So
Thank you all for the opportunity, and I'll be communicating shortly about some more deliberate next steps that we can take advantage of. We will be re-energizing our behavioral health caucus. We will have our first meeting on the 3rd at 5 o'clock via Zoom. And I'm working on getting some folks to come in and speak about some of these specific programs and what they mean and how they work. So stay tuned.
Yes.
Very much.
And
Thank
I
you.
think at this point, we're supposed to hear a number of DHHS reports. I see Amy LaChance is out there. We'll take those in the order in which somebody's available. And I don't know who's, oh, there's Molly. Hello, good morning. So maybe you can help steer us through the next section and who's speaking next.
Sure. I am going to set a record for report timing and see if I can report mine in under 60 seconds. And then we'll have, honestly, either Amy or Betsy jump in. I'm not sure if either of them have a time constraint, and we'll ask them to Teams chat that to me. And so once I'm done sharing the 1470 report, I can let you know who's next. But good morning, I'm Molly Bogart. I'm Director of Government Relations for the Department of Health and Human Services. And I am reporting very briefly on the LD 1970 main care rate change, which was, the bill was a resolve regarding reimbursement for providing inpatient care to individuals with acute mental health care needs. And it was about one rate for discharges from the Southern Maine Healthcare psychiatric unit. We made that rate change as it was provided for in the law, effective October 1, 2021 for all discharges, and submitted the state plan amendment to CMS on November 10th. And I just wanted to flag that, you know, we had talked in the context of this bill last year about how we were looking to do a provider-wide assessment of the rate for psychiatric inpatient care. And we are going to be prioritizing that at the beginning of this calendar year. It's long overdue. And as you heard us talk about in the context of this bill last year, having various provider-specific rates without a solid methodology behind them is not sustainable or equitable, or we would argue good policy. And so we look forward to having that rate review and proposing something to you in the coming years. But in the meantime, we have implemented the bill that was passed last year. And I can take any questions.
I'm not, yes, for Senator Moore.
Just real quick, was it 1970 or 1470?
1470.
14. Thank you. Thank you.
Yeah, no problem.
Any other questions? I don't see any. Thank you for bringing that succinct report.
I forgot to hit my timer, but I'm glad we got through it. I will hand it over to Betsy Hopkins next. She's our Associate Director for Intellectual and Developmental Disabilities and Brain Injury Services at the Office for Aging and Disability Services.
Good morning, everyone. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. Happy to be here this morning. And as Molly mentioned, I oversee the developmental disability and brain injury programs at DHHS. And as you know, the 130th Maine legislature directed the Commissioner of Health and Human Services to convene a task force to develop and make recommendations on rules and procedures regarding the rights and basic protections of persons with acquired brain injuries. And I'm here to present the final report, which includes recommendations from this task force that have been proposed. As directed in the legislation, the task force included experts in the field of acquired brain injury, providers of services to persons with acquired brain injuries, advocates for persons with acquired brain injuries, and then representatives of the Acquired Brain Injury Advisory Council. The task force met 5 times in the fall of 2021. And the following are the areas that the recommendations covered. And then I was just going to share a couple of examples from each of those areas, and then happy to take any questions that you may have at the end. The first area were the regarding the basic rights of all recipients. A couple of examples of recommendations included the right to be treated with respect, acknowledging diversity of culture, beliefs, gender, sexuality, and lifestyle choices, the right to self-determination in aspirations, goals, and lifestyles. The second area covered were rights related to participation and support in treatment. A couple of examples from that area include right to maintain natural support systems such as family and friends, including with individual, formal, and informal networks of people, and then to have the right to receive individualized support and treatment in the least restrictive environments. The next area included rights related to community residential services. Some example from those recommendations include to have the right to information and materials of community activities, to be involved in those community activities involving, including who facilitates access to the community, and then to have the right to live in a community of a person's choice. Rights related to employment was another area covered. One example of that would be that a person has a right to be employed and have the right to competitive integrated employment and to work at a job that pays at least minimum wage in a place that includes people with and without disabilities. Another area was around due process, rights that cannot be waived or restricted if under court-ordered guardianship, and then also the right to raise objections to decisions made about your individual care through complaints in an appeals process. The department would like to take this opportunity to thank the task force for their time in meeting and drafting these recommendations. The deadline for adopting the rules for this are July of 2022. It is important to note, I think as Molly noted it when she sent out the report to you all, that the recommendations included this report don't necessarily confer our support from the department for a recommendation, but the department is carefully considering each recommendation as it promulgates rules related to this chapter. Thank you for your time. I'm happy to take any questions if you have any.
Thank you. Betsy, are there any questions related to this report? I don't see any. So should we go to Amy LaChance? Welcome.
Thank you. Good morning, Senator Claxton, Representative Meyer, and members of the committee. My name is Amy LaChance, and I am the Drinking Water Program Manager for the Maine CDC. And I do have a brief PowerPoint presentation. Molly, were you going to put that up, or should I?
Can stick that up right now. Can folks see my screen?
Yes.
Great. Take it away, Amy.
Yep, next slide. So we are here to talk about the Act to Strengthen Testing for Lead in School Drinking Water. This act was promulgated to ensure that all kindergarten through 12th grade Maine schools sample all taps used for any consumption for lead. It was amended to state that the sampling costs cannot be transferred to the schools and that an annual report must be submitted to the legislature, which was just done. Next slide, please. So the rules that were promulgated pursuant to the act had the procedure for this type of sampling. It talked about the method for sampling and the follow-up to the sampling. It was amended to state that that the water must stagnate for a minimum of 8 hours prior to the sampling, and the level of concern was changed from the original 15 parts per billion down to 4 parts per billion, and it was stated that public notice to the school community needed to take place within 5 days of the school receiving the results. Next slide, please. So the money for this has come from the federal government. what we call our WIN grant, Water Infrastructure Improvements for the Nation. We are using this money to cover all of the sampling costs for the schools. The federal money does come with the caveat that it cannot be used for lead abatement, however, but we are making sure that we're covering all of the costs for the analysis. Next slide, please. So this is the timeline. In August of last year, we got some volunteer pilot schools that we worked through our process with, and that volunteered to do the initial sampling. As of October 1st, we had a program set up where schools could order bottles. We are partnering with A&L Laboratories, and we essentially the school would go through and fill out a spreadsheet that would list all of their sampling locations and send that to A&L Laboratory, who would then generate the labels and provide the bottle kits to the schools, so that all they needed to do was fill up the bottles and send that back. We do currently have in place a May 31st of this year deadline for the schools to complete testing. We were hoping that the schools would not be burdened with all of the COVID situation this year. Unfortunately, that's not the case. So we may end up having to look at potentially extending this deadline. But for now, we're hoping to keep people on track. I think a fair amount of schools may have waited until after the turn of the calendar year, but we're hoping to move ahead with a lot of them at this point. Next slide, please. So this is what we've got so far. We have a total of 710 schools that are subject to this requirement, and 13% of them have tested so far. Like I say, I'm hoping that we are about to send out another reminder. We've done a lot of outreach on this, which I'll go into in a minute, but we're about to send out another reminder, and I'm hoping that we're going to start picking up the pace here. Next slide, please. So far, the testing results, we are showing about 30% of the samples that have come back. So out of these schools that have sampled, we have a little over 2,000 actual sample results back. About 30% of those are over the 4 parts per billion. And the large majority are lower than the 4 parts per billion. This is about what we were expecting based on what we've seen in other states. Next slide, please. So part of this is that the schools need to report to us whether they have taken abatement actions. And I'll get into what those are in the next slide, but essentially about the same percentage, around 30% of the schools are engaging in abatement activities, or at least have reported to us the abatement activities. Next slide, please. So these are the types of things that people are doing. Routine flushing, this is something that we really try to educate schools about the advantages of after school vacations, certainly at the end of the summer, even sometimes on some schools are doing it after weekends, just going through and running the water. The worst case scenario is the water that's been sitting for a long period of time in the tap. And so we like to have people move that water through the fixtures. Other actions are the cleaning of the aerators so that the particulate lead does not stay in the aerator and continue to impact the water. Some schools have just shut off fixtures. If there's fixtures in, say, in classrooms or in laboratories or things like that, and they're not necessary and they had high levels, they're just shutting them off or putting do not drink signs on there. Some schools have provided bottled water. A lot of the main response would be replacement of fixtures. A lot of the fixtures are older prior to the ban on lead being used in fixtures at used to be 8% lead was allowed in fixtures. Now it's only 0.25% of the wetted surface. or installing filters, or potentially getting at the corrosion control concerns. Next slide, please. So these are the things that we have been doing in order to provide outreach. There's a big list there, Molly, if you can kind of scroll through all of those. Yeah. So we have done multiple webinars. We've gone to school conferences, school organizations. We have a great partnership with A&L Laboratory where they are doing the they're passing out the bottles for us. They're running the results. They're providing us with the results. We are also partnering with some organizations that are helping us with our outreach and our education. We have put everything on our webpage, and the easiest way to get to it is just to our main webpage, and then we have a link to our Lead in Schools under What's New. We have generated a lot of guidance documents, how to do this sampling, what do my results mean, what do I do if I have results over 4 parts per billion, how can I explain this to my, the school's parents and staff. A lot of documents out there. We have videos that were produced that show specifically how to take the samples and how to make sure that things are done correctly. We are sending out flyers to try to make sure that schools are aware of this. We're doing this through multiple channels. And then the results, let's go to the next slide and I'll talk about that there. So the follow-up is what we're doing is we are looking at the lab results. We are posting all of the test results on the web page. That's that same web page that was there before. That I think is going to be very helpful for people. We don't have the bandwidth to respond to lots of requests that might come to us on what the results are at individual schools. So we just want to be completely transparent, get all that right out there. We give a little bit of time before we put it out there so that the schools can do their public notice in accordance with the regulations, but then we put it all out there. We take a look at the public notices that are sent. We follow up with schools that have not done the public notice. We will, once we get to the deadline, we will follow up with schools that have failed to collect, and we are answering questions. Anybody that calls us, we're responding. What we are not doing, and I want to be upfront about this, is that we're not looking at every single result that is over 4 parts per billion and making a phone call back to the school and working through the process. We don't have the staffing to do that. We didn't get staffing with this provision. So what we are doing to try to get at that instead is that we've put together some really extensive guidance documents which are available, which talk about resampling and how to resample, to get resamples of the immediate first draw, but also to do some sampling after the water has been allowed to flow for a bit to determine, this is what we call investigative sampling, to determine whether it is the fixture, the water that's been sitting in the fixture, or whether it's the water further back in the plumbing that is a concern. We explain how to take a sample right immediately after the service line coming into the building to kind of key in on whether that service line could be a potential concern. In the most cases, it's the fixture with regard to schools. The other thing that we do, well, we're thinking that with the public notice going out to the parents and the school community, that a lot of that abatement will be driven by concern within the community, but we want to make sure that the school knows what to do. We're also hoping to get some, hoping to get some new staff to deal with this issue in general, and also, our other concerns with lead in drinking water. We are working on that. And then the other thing I wanted to mention is that the federal lead and copper rule revisions were promulgated last month in December of 2021. Those do have provisions in them that municipalities must sample 20% of their schools and childcare facilities every year. So in other words, a school all schools and licensed childcare facilities within a municipality providing water will get sampled once every 5 years. And that goes into effect. The rule has been promulgated, but it goes into effect in 2024. So there will be follow-up sampling on an ongoing basis for schools. I think that was all I had. So any questions that I can take, I would be glad to answer.
So Representative Zager.
Thank you, Mr. Chair. Thank you so much, Ms. LaChance. How is the data reported to the schools? In other words, is it an over/under, or are they given a quantification?
They're given lab results. They're given a quantification of the individual results.
Okay, thank you.
Representative Javner.
Thank you, Mr. Chair. I have a number of questions, so you just tell me how you would like me to proceed. My first question is, where is this A&L Laboratories located? Is it in Maine?
Yes, it is.
Perfect.
In Auburn. It's in Auburn. It's a great outfit.
Great. Can I ask another one?
Sure. Keep going. Don't ask.
How many pilot schools are there? You mentioned 710 schools that meet the requirements, but how many are actually in the pilot?
So the pilot was just last August. We wanted to run through a couple of schools early to make sure that this process was sending the bottles back and forth and getting the results reported took place. So all 710 are required to do the sampling. The pilot was only, maybe 5 or something like that. It wasn't a lot of them. They just volunteered to go first, essentially.
Heather?
Would you like to take a question from Senator Baldacci first before you?
Oh, keep going.
Okay. You mentioned that there were 2,380 samples taken, but only 710 schools that are required to do this. So how, I know that you mentioned as well, they are allowed to retest. And then at what point, how often are they allowed to retest before abatement needs to occur?
So first of all, the sample number is based on the fact that these 710 schools have multiple locations that they are taking their samples from. They have to sample every single tap and their kitchen and their drinking water fountains and their bathrooms and everywhere that somebody could potentially be drinking the water. That's why there's so many samples per that number of schools.
And then how often are they allowed to retest before abatement?
Well, abatement is not required by this legislation. It is, we strongly recommend it. We provide a lot of guidance on how to do it. But it is likely a process. I mean, there are some schools that struggle with results. They're not testing out of dealing with the problem. They're using the investigative testing to figure out what the problem is so that they know how best to tackle it. Whether, there's no sense in replacing fixtures if they know all of them are new and, that's not the issue. It's somewhere back in the plumbing. So that's what the resampling is for. And there's no restrictions on how much investigation they can do that way.
Great. And do you know, like for those schools that have tested above 4 parts per billion, what the reaction has been in the community? Do we have any feedback from that yet?
We have gotten questions from parents and from teachers and that type of thing. But I don't know of any, we've not been alerted to any particular concerns. I think that people are concerned about high levels and they want to see something done about it. But honestly, I mean, it's just great getting the information and so that we know what the problem is and we can address it, because until we did this sampling, you just aren't going to know, and it's still going to be there all the time, but we just don't know. So.
Perfect. And then you mentioned your staffing issue multiple times. What level does your staffing need to be at in order to really be successful at this program?
We're hoping to add an additional staff. We have currently just part-time staff person at this point, but we are hoping to add one FTE to just focus on school lead. And then, like I say, obviously there's a lot of other issues with lead coming up in public water systems. So.
Great. And the guidance documents that they received, do we have access to that as well?
It's all on the website.
All on the
Yep,
website.
it's
Perfect.
on the website. Yep.
Thank you.
Absolutely.
All set? Senator Baldacci, welcome. And do you want to introduce yourself?
Thank you. I'm Joe Baldacci. I represent Senate District 9, which is the city of Bangor and the town of Herman. I was in the IDEA committee for a while on a bill, so I apologize for not being here at the same time. But thank you, Ms. LaChance. Thank you very much for your work. And thank everybody that's working on this. It's a very important issue. Bangor School Department took part in this test. Is that correct? Okay, because I read the, and I don't know what was the exact lead level that they had the first, because my understanding is that Bangor High has retested since the first test.
I'm looking at the results right now. I see a lot of low results, some in the single digits, above 4, but in the single digits, a lot of zeros. 123 parts per billion at a kitchen food prep sink.
So they said it indicated, the superintendent indicated that they were retesting on January 22nd. Did that occur?
I can't answer that right now, but I can get back with you on it for sure.
Yeah, if you could, I'm very interested in the situation of Bangor High, or obviously Herman High School as well, if they've been involved in the testing. Because the superintendent put out a statement that they were working and we're going to get back to people after this retest. But there was a firm, one firm that does all the testing, is that correct?
A&L Laboratory. The schools themselves, the personnel there are filling up the bottles themselves, but the bottles are provided, the kits are provided, they fill them up and they all go back to A&L Lab, which we have contracted with.
Great, and the statement put out by the superintendent indicated that they had Haley Ward Consulting, but that firm was not hired to do testing.
That they likely hired that firm to do some follow-up once they got the sample results.
Okay.
So to assist them with investigating and then abating the issues.
No, thank you. And I know that when we passed this rule, we did not include the abatement part of it because we wanted to start kind of on the public education part of it. It's assuming that your office is still working with people about abatement issues and those type of things. In terms of how to.
Oh, yes. Yeah, we have guidance documents on that. We will answer questions that come to us on that. We provide as much assistance as we can with that. So yes.
Yeah. Okay, and these results are all publicly available?
Yep, they're right there. You can scroll right through them. So
okay. Yeah, if you can let me know how the most recent testing went, I would appreciate it. Thank you very much, Ms.
Yep, we absolutely will follow up with you, and it will take a few weeks to, if they did sample on the 22nd, there'll be a lag before we get the results, but we'll make sure to get those to you.
Thank you very much.
Absolutely.
It looks like there's 20 taps at Bangor High School. And if you go to this website, I've quickly found a teacher's lounge I wouldn't want to drink the water out of with a level of 170, but that pales in comparison to the 3,500 level that was at another school. So I assume that tap has been decommissioned and, whatever else you need to do. But it's a very instructive website. So I encourage everybody to check out your local schools and see what you can learn. And it's posted to the nearest decimal in terms of levels for lead.
This is a good tool for parents, Mr. Chairman, to work with their school departments to make sure they're following through.
A lot of parents would like to know that it's okay or not okay. It's working to the extent that we were able to fund it focused on education. So thank you for making this process work.
Absolutely.
And thank you for using a local Auburn entity.
You're doing great work.
I've used them for years for my wells. Anything else that anybody would like to ask of Amy LaChance related to the lead effort? Very good, thank you.
Thank you.
So I see we also have Maya Ferris here. Does she want to?
She's one of my staff people that are working on it. She was just wanting to listen in. She's done a lot of the great work on the guidance documents and wanted to hear this report. So
Your opportunity to give her a kudos. So
absolutely,
this is good work, and I hope the other schools pick up on it. It's working the way it was intended, so that's a good thing. Are there any other questions we want to address right now? Any other reports you want to share with us, Molly, or is that going to conclude?
I think that will conclude for the morning, but among the emails you've gotten from me are the slides for 1 o'clock today. So just want to make sure you've seen those.
Okay.
We'll see you then.
All right. So is there any other business we need to attend to, Sam? I will say that I really like the format of the people responsible for the report, doing the delivery, and giving us a chance to ask questions of informed folks. So that seems to be working really well, and I want to thank Sam and Anna for coming up with that model. I think that's going to get us more reports reviewed and better questions asked. Anything else anybody wants to bring up before I entertain a motion to adjourn until 1 o'clock? Not seeing any, I will accept a motion to adjourn until 1 and see everybody back then after they seconded, and all those in favor. Moving right along. Thank you, folks. We'll see you at 1.
Good afternoon, Senator.
Good afternoon, Representative Meyer. How are you?
I'm well, thanks.
Did you have a nice leisurely lunch?
Somewhat.
Compared to some. Welcome back, everyone, to this afternoon session of Health and Human Services Committee. We'll be hearing some more reports. These will be coming primarily from the Office of Child and Family Services. Welcome, Dr. Landry. And Molly Bogart, welcome to you too. And we've created legislation that asked for a report back, and this is an opportunity to begin to hear some of those reports back so that we know how we're doing and how things are progressing. So are you going to start, Dr. Landry, or is Molly?
I can
Go ahead, Molly.
just to give you a sense of what Dr. Landry is going to present. So there were a few reports that you received a while ago from us in response to letters that you sent, either with bills that were ought not to pass or through resolves that required a short report back. And so we'll start with those, and then Dr. Landry will go through the child welfare, children's behavioral health, and early childhood education updates. And then we will stick around for questions for as long as you need.
And I'll apologize because I'm going to step away in about 20 minutes because I have to go to Ledge Council and plead for an after deadline bill. So I will turn the chair at that point over to Representative Meyer. So carry on.
Thank you very much. And Senator Claxton, Representative Meyer, distinguished members of the Health and Human Services Committee. I'm Todd Landry. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services, and pleased to be with you today to share some information related to the Office of Child and Family Services on the topics that my colleague, Ms. Bogart, just mentioned. Before I begin, I would like to take just a moment to acknowledge and appreciate the staff of OCFS across the office, whether in child welfare, child care, children's behavioral health, children licensing, or our support areas. They have done a remarkable job continuing to meet the office's responsibilities and duties despite the enormous challenges that we all have felt during the past 2 years of the global pandemic. As the Child Welfare Ombudsman shared with you on Tuesday, these challenges have impacted the work of child welfare staff, and I would add, all of the staff in OCFS. And I wanted to begin my presentation today with a public thank you to our OCFS public servants. I do have a slide deck that I would like to go through. So if you, with your permission, I'd like to share my screen on that.
Please, I think Karen can make that happen if it isn't already available.
Here we go. Senator Claxton, can you see that now?
I can.
Fantastic. I would like to begin with some quick summaries of responses to committee letters that we received at the end of the last session. And I'd like to start with LD 699 as it relates to kinship navigation services. As we all know and as we all appreciate, the role of relative caregivers and kinship caregivers within child welfare is vitally important and can be a tremendous resource for children and families involved with child welfare. We have continued to support our kinship services by funding the kinship program of the Adoptive and Foster Families of Maine. I'm also very pleased with the work of AFFM and OCFS working together with the University of Washington and Casey Family Programs on a Kinship Navigator collaborative project in combination with other states to develop an evidence-based Kinship Navigator program that it is hoped will eventually be submitted to the Federal First ACF Clearinghouse. I also would like to say thank you to Attorney Mary Bonato for her assistance and direct outreach with her to support underserved communities, including LGBTQI+ and homeless youth. AFFM works with Maine Family Planning to offer a training on healthy relationships to resource families, including kinship families. I know this was a part of LD 699 during the testimony, and I'm very pleased to say that we have been successful in working with Attorney Bonato. We've also asked, AFFM, has asked Attorney Bonato to propose a member of GLAD to serve on the AFFM board, which provides oversight to not just AFFM, but also the collaborative work that I mentioned a moment ago. I'd also like to say thank you both to Attorney Bonato and Brandy Brown, who you may know as the Gender Clinic Coordinator at MMC, Maine Medical Center, for their work on and their participation in a work group working on revised policies, including a new LGBTQI+ policy. So my thanks to them, and we have more information regarding our work around kinship navigation services in the letter that we provided to the committee. On LD 1460, it was a request and some information related to policies and how policies were, which policies were updated in 2021, as well as a particular focus on the family team meeting policy. Again, more information is available in the letter we sent the committee, but I do want to highlight the 5 policies that were updated in 2021, in addition to the 3 that are now in finalization process. One of the policies that was updated and concluded in 2021 is the family team meeting policy. We had committed to have that policy revised, updated, and released in the fall of this year, and that occurred in November of 2021. It provides clear and consistent practice expectations to staff regarding how and when FTMs should be convened. This, like all policies, was revised in collaboration with the subject matter experts at Cutler Institute at USM. It also received feedback and edits from both the Maine Child Welfare Advisory Panel, which includes the Child Welfare Ombudsman, as well as an opportunity for all of OCFS child welfare staff to provide input to these policies before they are finalized. The updated policy also aligns with other recommendations that we received during the course of 2021. The letter does provide additional information, including the link to the finalized policy for your review and consideration. The next letter that we provided information on was LD 497, which was an update regarding Family First. You can see some of the key activities that happened during 2021 as it relates to Family First implementation. Happy to say that Maine was not only the first state in New England to submit its Family First plan to the federal government for approval, we were the first state in New England to receive approval of our plan, which was implemented, or began implementation, I should say, on October 1 of last year. You can also see the other work that has been going on related to implementation of Family First, as well as some of our current activities. It's important to note that all of this work was done in collaboration with a group of providers and stakeholders who engage with OCFS on our Family First efforts through town halls, individual conversations, and work groups. And that included both parents with lived experience in the child welfare system, as well as individuals from the Youth Leadership Advisory Team, which are youth who have had previous involvement with the child welfare system. Additional information is included in the letter that was provided, and would be happy later at the end of this program, or in the end of this presentation, excuse me, to answer any questions that you have. One of the components I'd like to highlight as it relates to our Family First implementation is the state agency partnerships for prevention. This chart shows a summary of all of the different types of funded programs, services, and efforts related to primary prevention, secondary prevention, and tertiary prevention of the offices of DHHS, as well as the Departments of Education, Labor, and Corrections. My thanks to my colleague, Christine Theriot, who has led the implementation work on Family First, as well as her work in helping to guide the state agency partnership for prevention effort. This is also done in collaboration with the Children's Cabinet. All of the departments listed on this chart are members of the Children's Cabinet, and we use the Children's Cabinet as a way to convene and help guide some of this work going forward. I believe Representative Stover had asked a question about what type of programs and services were funded by the department in relation to prevention efforts. We believe that this chart at least provides a good inventory of ways that the department, as well as the Departments of Education, Labor, and Corrections, all serve to focus efforts, programs, and services around these areas of primary, secondary, and tertiary prevention. I'd like to now move on to some updates as it relates to child welfare. The information that is included in this update and presentation primarily comes from our annual report on child welfare that was released on January 4th of 2021 and provided to the committee and also publicly posted on our website. Much more detailed information on any of these topics can be found in that report, but I'll try to focus on just some of the highlights for the purpose of today's presentation. I'd like to start by sharing some of the information about some of our recent efforts for improvements in child welfare. So the next few slides gives you some indication of some of the work that we have recently done to help further improve our work in child welfare. Some of this you have seen in other presentations, other pieces of it might be new to you, but you can see some of our work there, including our work with providers around effective coordination on child welfare matters. We also have information there on the establishment of protocol agreements between law enforcement, hospitals, and child welfare. And I've already mentioned some of the work related to family team meetings that is captured on this slide as well. We also have continued our work around exploring opportunities on how we can support engagement between parents and the child welfare system. I'm very happy to be able to say that we have moved forward with that and provided funding through our USM Cutler Institute Cooperative Agreement for the hiring of 2 parents with lived experience that will be part of the USM work in our cooperative experience going forward to not only provide perspective and assistance and guidance as it relates to policy development, but also the training of our child welfare staff, including our frontline caseworkers. We're also continuing to work towards the second 2 on this chart regarding national best practices regarding standby and after hours coverage, as well as looking at our assessment practices, specifically timeframes and the tasks associated with the work of assessment and investigation as we go forward. One of the things that you did hear from, I believe, the Ombudsman on Tuesday, and we certainly are in alignment with her regarding support on her recommendation and our commitment to implementing the safety science model within our work within child welfare. After experiencing that safety science model in the review earlier in 2021, and with the support, as I said, the Child Welfare Ombudsman and others, we made the decision to implement the safety science model of critical incident reviews in child welfare. We have established 2 limited period positions to help guide and facilitate this work. The training on staff has already begun, and we look forward to implementing those critical safety reviews and using safety science in those reviews in the next few months as we begin to implement this work on a going forward basis. My thanks to the Child Welfare Ombudsman for her support of this, as well as her commitment to participating in those critical reviews going forward in the future. We have previously talked in the committee about the work related to the new comprehensive child welfare information system. You may remember in 2018, the legislature approved the development and implementation of a new comprehensive child welfare information system. I am very happy to be able to announce that the new Katahdin system, as our staff chose to name it, was launched for use by staff and is in full operation as of January 18th, earlier this month. All of the MACWIS data, which was our prior system, has been converted over to Katahdin. And you can see some of our pre-implementation activities that occurred, including intensive training for all OCFS staff. Very happy to be able to report to you that Katahdin was implemented on time and on budget. We have more specialized trainings coming forward in the coming weeks, and we're also looking forward in the month of February with the planned implementation of 2 portals into that Katahdin system, one being our resource parent portal and the other one being our mandated reporter electronic reporting device or system, both of those coming in February. I know some of you have asked about information on data on the number of children in state custody. This chart shows the number of children in state custody on a federal fiscal year basis back to October of 2017. As you can see, over the last year, from October of 20 to October of 21, we have seen a reduction in the number of children in state custody. I think it's important to note that this number primarily includes children under the age of 18, of course, in state custody. However, it does include those on voluntary agreements, sometimes known as our V9 agreements, for children to extend their stay in state custody. That number has grown in the past year as federal requirements or federal eligibility requirements were loosened during the pandemic to allow more youth to stay in that voluntary care. We currently have about 77 youth over the age of 18 that are in that situation. Currently, I will tell you, we have approximately 2,275 children in care as of this week. And so that is where we stand as of right now. I think it's important to keep in mind there's obviously numerous factors that drive the number of children in care. The graphic on the right highlights some of those factors. I also want to indicate that there's impacts based on all of these factors, including challenges and concerns and the work of the court system in ensuring that timely hearings are being held on these court cases. My thanks to the Maine Judicial Branch for their work in partnership with us to continue to prioritize those hearings during the pandemic and on a going forward basis. I would also like to mention that during 2021, OCFS did continue the implementation of our permanency review process to monitor the timeline to permanency in cases and work to address any barriers to permanency. As it relates to permanency, one of the things I believe you heard about in last week's Government Oversight Committee hearing was the extensive federal oversight that occurs for the child welfare system. One of the things that includes is the federal government setting certain benchmark goals for all states and territories regarding time to permanency. There's really 2 key pieces of that measurement. One of them is around permanency within 12 months of removal. The second federal measure is permanency essentially within 24 months of removal. Very happy to say that we have made steady progress on those federal benchmark goals, and our data on that reflects that. So this chart indicates the federal goal for permanency in 12 months as well as permanency in 24 months. These 2 goals essentially go hand in hand. So if, depending upon what your percentages are, if you achieve permanency in 12 months, then obviously that's going to impact the percentage that achieve permanency in 24 months. But you can see the federal goal there is 40.5% for permanency in 12 months and 43.5% for permanency in 24 months, basically. You can see we've made steady progress on that first goal, rising to approximately 33% of permanency of children achieving permanency within 12 months, at the same time trying to maintain those high numbers of permanency within 24 months. While we still have a ways to go, and this is certainly reported, I know the permanency in 12 months is reported monthly on our dashboard that's publicly available. We look forward to continuing to make progress towards achieving these goals, and would be happy to share more about that with you if you have any questions. One of the things that certainly impacts children in state custody from a outcome basis and a success basis are a few pieces that are shown on this chart, which summarizes where children are currently placed. Nationally, about 35% of children in state custody around the country are placed with relatives or kin. I'm happy to say that Maine exceeds that number, with 41% currently placed with relatives who are in state custody. As you know, we have a statutory obligation to place with family members whenever safely possible. I believe the Ombudsman shared with you some of her perspectives on the success of the department in doing that when she met with you on Tuesday. I would also like to point out the last two pieces on this 5-bubble chart on the left-hand side, and that has to do with the number of children in custody placed in what the federal government calls congregate care settings. For us, those would be those children's residential settings. We have currently 3% of our children in care placed in those residential settings. The average nationally is 10%. Several states exceed 15%. We certainly want to have children who are in care to be able to grow up or to be able to be placed whenever possible in a home or a home-like setting. And so we want to focus on that and have done so for the past several years. Happy to say, as I said, that Maine is only at 3% of youth placed in those congregate care settings. I'm also happy to tell you that is the lowest percentage in the country. And we continue to receive phone calls from other states in the country about our success in having more children placed in family settings as opposed to congregate care settings when they are placed in state custody. Two other pieces that I think are also important as it relates to children who are in state custody. One of those is placement stability. I think we would all agree that it is best for children if we can minimize the number of times that they move while they're in state custody. So this is one of those federal measures where a lower number is better. The federal government has set a standard, or I shouldn't say that, the average in the country, not a standard, but the average in the country is 4 placement moves per 1,000 days of care. For Maine, our rate is 3.1, significantly below that national average. From a reunification perspective, the majority of children exiting our care in federal fiscal year 21 exited to reunification, about 50% of the time, while 44% of children who exited permanency exited to either adoption or permanency guardianship. This is very similar to current national averages and a significant improvement from federal fiscal year 17. One of the impacts related to reunification and timeliness of permanency has been the issue of substance use. Substance use continues to be a significant factor in the lives of many children and families in the state of Maine, and that includes families who are involved with the child welfare system. Our latest data available indicates that substance use was a risk factor, not necessarily the only factor, but a risk factor in 50% of all removals in 2019. This chart illustrates a significant increase in the impact of substance use on child welfare in the last 20 years, both here in Maine as well as nationally. When substance use is a factor in a case, I want to point out that our data shows that it does not change the percentage of the time that a family is able to successfully reunify. It's still about 50% of the time. However, it's important to note that when substance use is a factor in a case, it typically takes on average 3 months longer for that reunification to occur when compared to those cases that do not involve substance use. As a result, this does tend to have a significant impact on some of our timeliness to permanency outcomes and our achievement related to those areas. And I will conclude with a couple of slides as it relates to what I consider to be one of the most important, if not the most important aspect of our work in child welfare, which is our staff. And I would be remiss if I did not take this opportunity to reiterate the impact of COVID-19 that we have experienced on staffing. For example, staff have had to take time away from work in order to complete isolation or quarantine for themselves, or support that of a family member who is isolating or quarantining. And that has increased recently related to the Omicron variant. Despite this challenge, OCFS staff have continued to meet the statutory obligation to receive and investigate reports of alleged abuse and neglect, and where necessary, take action to keep children safe. I want to again thank our staff for their continued dedication and ability to surmount these significant challenges. Their continued focus on child safety is appreciated, especially in light of some of the short-term absences for their colleagues. Earlier today, OCFS released the annual workload report that provides additional information, including the data from our workload analytic tool. The report indicates a need for additional staff to balance the workload of child welfare based on the results of that tool and the analysis. The report also documents Maine's average vacancy rate during 2021. It also provides additional details related to child welfare workload and workforce. On this chart, I've already discussed efforts to reduce duplicative and sometimes perhaps less necessary work in investigations, to examine our national best practices related to our timeframes and implement any needed changes, and best practices regarding the experience of staff related to after hours and standby coverage. And I've also mentioned science within child welfare. What I haven't talked about on this chart is the field instruction unit. The field instruction unit provides college students pursuing a degree in social work with an opportunity to work within OCFS to gain college credit. This includes attending our foundations training and undertaking other efforts to prepare them for potential future work within OCFS upon their graduation. OCFS some years ago had an FIU, a field instruction unit, and we noted that many of the staff who have been with our organization and become leaders in our organization started their work with OCFS when they had experience with a field instruction unit. We're happy to say that we are reestablishing the field instruction unit in partnership with our work with the Cutler Institute. We believe we'll benefit from the assistance of these students and the availability of social work graduates with experience in child welfare once they graduate. Child welfare, as we have discussed before, is complex and challenging work. The field instruction unit gives students experience to determine if child welfare is going to be a good fit for them, and we look forward to launching the field instruction unit in 2022. Some additional information related to our staffing that I'd like to speak to just shortly is we currently have 425 child protective caseworker positions. Those 425 include 70 new positions since 2019. As you may recall, in the first regular session, Governor Mills sought 15 new caseworker positions in the biennial budget. The legislature approved 10 of those positions, effective January 1, and 5 more effective on July 1. The 425 number I quoted includes those first 10 positions. Some of you have asked about caseload. The average caseload for caseworkers currently is 10.6 cases per worker. I want to mention this does not include in the calculation caseworkers who do not handle cases, such as those who answer child protective hotline calls through our intake process. Nor does it include caseworkers with less than 4 months of tenure or experience, as they are still going through the training and onboarding process. As noted in your presentations that you heard on Tuesday, caseload is not necessarily a good indicator of workload, which is why, consistent with national best practices, OCFS has chosen to focus on workload as a better method of measuring and adjusting cases. More on that topic can be found in the annual workload report that was released earlier today. Some of you have also asked about what the pay level is for caseworkers. The annual starting salary for a caseworker, excluding overtime, is approximately $52,000 per year. That salary level can go as high as over $66,000 annually. This includes the $5 per hour stipend, which was added to the salary of child protective caseworkers effective in 2018. I'd also like to point out that OCFS has developed and implemented a system of clinical support services for child welfare staff statewide. We have contracted with Spurwink, and this began, I believe, in 2019, to provide this service that includes ongoing support and a structured response to critical incidents, which have historically had a significant impact on staff. We've continually received positive feedback on the clinical support services from staff throughout the state. I will, though, conclude this part of the presentation by saying, even with these improvements and additions, the department agrees that further support is needed for child protective caseworkers and staff. That's why, since 2019, we have focused on supporting child protective staff by increasing pay, enhancing training, and securing funding for the new positions to improve workload. The department also convened a work group of frontline caseworkers in 22 in recognition of the concerns about night and weekend coverage. That led to several recommendations that the department implemented in 21. Furthermore, Governor Mills plans to address the concerns about child protective staffing on nights and weekends in her supplemental budget proposal. And I believe the chairs have asked for me to take a pause at this moment before we talk about children's behavioral health and childcare to see if you have any questions specific to child welfare.
That is correct. Thank you, Dr. Landry. So you've provided us with a great deal of information. So questions from the committee on the OCFS responses to 699, 1460, 497, and then the child welfare update. And I see a question from Representative Perry. And it looks like you're unmuted, but we can't hear you. Try again.
Thank you.
There you go.
Yeah. Okay. First of all, thank you. And thank you, Dr. Landry. I'm always very interested in your reports. I do have, and I think there was something that came up in the reports on Tuesday, was something that the staff kept saying that they had changes in policy come down one after the other, and they had trouble keeping up with it. I suspect I know the period of time that happened. But the question that I have is, has there been any effort to look at or measure what staff morale is at this time? There's still a lot going on, which is good. There is definitely some work to gain supports, but also how is staff responding to this, and what is this doing? And because staff morale is so important in terms of getting the work that you want done.
Well, Representative Perry, thank you very much for your question. I want to start off by saying, when I first came to the state in 2019, I had the opportunity at that point to meet in person with all of our staff. And within about, I believe, 5 weeks, have met with all of our staff in each of our district offices around the state. One of the things I heard very loud and clear from them was the way that they felt from what one of our staff termed the whiplash related to policy changes that they had experienced previously. My commitment to them was that we were going to do everything we could to minimize that quote unquote whiplash factor because we know how that can impact our staff. That is in part one of the reasons why we have been very diligent about working with the Cutler Institute to ensure that we are very thoughtful about any policy updates and changes that we make. That's why we engage with the Cutler Institute, with usually representative teams of our staff that participate in the drafting of updated policies, And then as an extra layer of opportunity, take the time to get the input and invite the input of all of our child welfare staff on any new policy before it is implemented. That's also why we engage with the Maine Child Welfare Advisory Panel, including the Ombudsman, to give us that input. That takes additional time. I want to be the very first one to admit that. It takes time to go through that process and give everyone the opportunity to review sometimes some quite complicated policies in order to give us input. But it's also been incredibly valuable. I don't think there's been a single policy that we have put out that hasn't benefited from that input for changes that we have made before it went into effect. The family team meeting policy, I think, is a really good example of that. We took an additional weeks of time in order to get that input in, and we made a number of significant changes to the policy before we finalized it. So I appreciate your question about that. I fully appreciate and heard loud and clear from our staff when I came in 2019 about what they were experiencing, and I believe the process that we've put in place may at times frustrate some folks because of the length of the time it may take, but I think we end up with a better product in the end. Regarding your second question on staff morale, one of the things that I have been doing since I believe April of 2020 is since we could no longer at that point go out and meet with staff in person in our district offices, we have been convening virtual town hall meetings, sometimes with larger groups so that we can share information more quickly with everyone, sometimes in small office level or district level meetings so that there's more opportunity for input and feedback and conversation. We have continued to do that. I will be the very first one to say, and as I think I've indicated already in my comments, that the pandemic has produced some significant increases in challenge and stress for our staff. I'm happy to say that I believe beginning in May of 2020, we have continuously provided surgical masks, gloves, sanitizer, et cetera, for staff in each of our district offices. And that was well before some of our recent changes or some of the recent changes around masks and mask effectiveness. But we continue to do that. We continue to try to be as flexible as possible with staffing or with scheduling and opportunities to try to adjust to the extent that we can. But I also want to be clear that the challenges have been significant, particularly for our new staff. One of the big challenges that we have heard from our new staff is they have missed the opportunity to work right alongside in person, right next to each other in their workstations to be able to get some of that contemporaneous learning. That quick on-the-fly learning that we know can significantly benefit, particularly new staff. And I'm very hopeful that we'll get to a point in the near future where we can return to more in-person activities in our offices to be able to benefit from that. At the same time, I think we will also be able to benefit from some of the benefits that we can still latch onto as it relates to some remote work as well. But through those town hall calls, we hope to increase information sharing. We want to increase the flow of information and sharing of concerns. And I believe that's one way that we have tried to focus on morale. But I want to be very clear. This period of time has been very stressful for staff, as I know it has for many of you and your colleagues. And that has certainly, our staff is certainly not immune to that.
Thank you. Senator Moore.
Thank you, Madam Chair. I have a couple of questions, if that's okay. Thank you, Dr. Landry, for your presentation. It's always very thorough and very interesting. Couple questions. When we're talking about the children that are under the age of 18 and state custody, and then you said there was a waiver where they can extend their custody, what would be some examples of why we would continue to keep them in state custody?
Good question. We can get you more specific details about the V9 program, but part of that V9 program is a voluntary opportunity for children who or youth who are about to age out of the system to be able to remain in state custody. Some of the things that enables them is to continue to receive case management support. There is federal financial support including some pieces for additional support beyond tuition reimbursement. So for housing supports and things of that nature that they qualify for through Chafee funds federally. There's also opportunities for some opportunities for them to continue to have support from each other through some of the other groups that we've talked about. We can get you a full list of all of the opportunities that are available for those that are on the quote unquote V9. And it's named that because I think that was the number on the form that they would fill out to complete that. So, but it's stuck. And so we continue to still sometimes refer to it as V9. But it does give an opportunity for those youth who wish to continue to get some of those benefits and receive those benefits, but it is on a voluntary basis. The federal government during the pandemic did provide some waivers to states for some of those individuals to stay on that voluntary agreement for a longer period of time. And it allowed those who had previously aged out, who did not choose to go on the V9 program, to voluntarily sign up after the fact, if you will. So those are some of the flexibilities that we receive from the federal government for some of those Chafee dollars and other aspects of that program. But we'll get you some more information on the details.
And how old, like how long can they stay on the V9 program?
Yeah, I believe they traditionally can stay on the program until they're age 23. But I do believe that with the federal provisions that they can now stay on the program until, and I'll confirm this, either age 25 or 26.
Wow. Okay, that's good. And then when we talk about the permanency numbers themselves, does that also include when we have children that have been reunified with their family or their parents?
Yes.
It does.
Yes,
So
that's all forms of permanency, reunification, adoption, or permanency guardianship.
that's good. Trying to think if there's one more. I think that was the last of my. Oh no! How many college students? I love the idea of that field instruction unit. How many college students do we expect that might be part of it?
I believe the program that we're doing with Cutler is going to start relatively small and then grow from there. But I believe we initially are going to be looking at 20 or more students for the first group. Again, we'll get you details on that as well, but that's the number I recall off the top of my head.
Great. Thank you. Thanks so much.
Representative Zager.
Thank you so much, Madam Chair. And Dr. Landry, really very informative and report, and it reflects tons of work. I was really pleased to hear about how low the Maine's congregate care statistics are, and also the placement stability, as well as the implementation of the safety science model. I recognize that that's underway. It's and it will continue to flow. I was hoping that you could comment on what I see as a paradox, as the number of people who are in this pandemic seem to be struggling with substance use. That the number of children in state custody has actually gone down since the pandemic began. You had a model showing 5 different elements, with the different things that affect that variable. Any thoughts? Anything you could elaborate on?
Sure, a few thoughts on that. One of the things that I would say that we committed to in 2020, despite the challenges of the pandemic, in 2020, we began a focused effort around permanency, and specifically looking at children and examining those cases very carefully around children who have been in care for after 6 months, and then again for those who have been in care for over 2 years. And so we specifically looked at those populations. One, for those that have been in care for at least 6 months, to make sure that we were doing everything we can to ensure they were on track for whatever the permanency goal is at that point. And those who have been in care for over 2 years, we really wanted to make sure we were looking at those cases, see what is the barrier and what's standing in the way, because we didn't want children staying in care for any longer than they needed to be. And I believe what we saw in late 20 and early 21 was many of the signs of the results of that specific focus around permanency. I believe we were able to knock down many of the barriers despite the challenges of the pandemic. So it really, and that certainly led to some of those increases in permanency during that time period. It was not, and I want to be clear about this, it was not an issue of a reduction in the number of children coming into care. We continue to see about the same number of children coming into care during the pandemic, except for maybe the first 6 weeks or so of the pandemic versus pre-pandemic. It was really much more of a focus on more timely exits to permanency. And so it really was not about some decrease coming in the front door, if I can use that term, but more of a focused effort on enabling children and families to exit the back door, so to speak, in order to achieve permanency.
Thank you. Really appreciate that.
Representative Craven.
Thank you, Madam Chair, and thank you, Dr. Landry. A lot of information, great work. My question is about congregate living. I wondered if you had counted children being treated for behavioral issues in the overall number of congregate setting placement.
If they are in one of our residential facilities, whether in-state or out-of-state, they're counted in that number, yes. But if they're receiving behavioral health treatment, for example, as part of their treatment, but they're residing, for example, in a resource home or with a relative caregiver, that would not be considered congregate care treatment or congregate care setting.
Right, thanks.
Seeing no other questions from the committee, I would ask that you move on to children's behavioral health. Actually, Representative Stover.
No, I just wanted to take an opportunity to thank Dr. Landry for the presentation and also for the very lively graphic of prevention that I thought was it was great. So thank you.
It is quite colorful. I will say that much. But there's a lot of information on that, and hopefully that helps to provide you with some of that information that you were looking for.
Thank you. I'm very visual, so it captured my eyes.
Great.
Are you referring, Representative Stover, to the state agency partnerships for prevention?
Yes, with
graphic?
the prevention, with the three.
So what is OCFS's relationship? Who coordinates that? Those relationships?
Sure. So one of the things I mentioned, Christine Thurio, who has been our Family First manager, working on Family First implementation. And this effort around state agency partnership for prevention really was born out of the work that Christine was leading with a number of other entities, including our counterparts within the department, as well as in those other departments that are listed there. So she, with the help of Anna Hicks and the Children's Cabinet, began to convene these meetings to talk more about this array of services, primary, secondary, and tertiary, and continues to be a focal point for continuing to lead those discussions within those offices and departments. I believe it's probably one of the first time, if not the first time, that we've had this inventory of these programs that specifically focus around these different types of prevention. You'll notice on there, for example, that Department of Education, primarily tends to be more loaded towards primary prevention versus not. OCFS probably has a little bit more weight towards, say, tertiary prevention, and certainly that's where our Family First work is involved. CDC has a significant amount of the work within the HHS around primary prevention and some secondary prevention. So it was very helpful, and I appreciate Christine's work on this because it put together all in one place, this inventory, so that we could all see that and better coordinate across the offices and departments. And again, my thanks to the Children's Cabinet staff, the staff from the different departments who are represented in the Children's Cabinet, I should say, for their work in helping us move that forward.
Thank you. Representative Stover, is your hand still up with another question? Or okay, thank you. Dr. Landry, carry on.
Great. Representative Meyer, may I ask, do you see that screen now?
We do.
Thank you. So children's behavioral health, a bit of a shorter update for you. But this information primarily also comes from our annual report. It was also released publicly on January 4th and provided to you at that time. Again, going to try to focus on a few of the updates related to children's behavioral health. One of the pieces that I am very pleased about the progress that we've been able to make within children's behavioral health is our federal system of care grant, sometimes abbreviated as SOC. As you may recall, this is a 4-year, $8.5 million federal grant that we received in 2020 to improve behavioral health services available to youth in their homes and their communities for those who have what the federal government titles a, quote, serious emotional disturbance, or what we would call a behavioral health challenge. You can see some of our activities on the left-hand side of this chart. Won't go in detail about that. More detail is provided in our annual report. I do want to pay particular attention to the call out there about our steering committee. Very pleased to be able to say that youth and parents or caregivers make up 55% of that committee. So that committee is primarily made up of parents and youth who are directly beneficiaries or were beneficiaries of children's behavioral health services. That increases family engagement, we believe, and certainly increases the family voice in treatment planning and service delivery. Happy to say that in the first year of this federal grant that ended in the fall of 21, we exceeded our goals on the number of children and families that were enrolled in that program. Keep in mind the first 3 counties in the first year were Aroostook, Penobscot, and Piscataquis counties. And then this year we've added 3 additional counties, and we'll eventually cover the full state by year 4 of this federal grant. One of the pieces that is a significant linkage between our Family First work and the work of children's behavioral health has to do with evidence-based practices and increasing the access and availability of evidence-based behavioral health practices and services in the state. Our full array of Family First services that were approved as part of our federal plan is shown here on the left-hand side of the chart. But I really want to just point out 2 of these as examples of the ways that children's behavioral health is attempting to and is increasing the availability of evidence-based practices in the state. One of those is the program that you see there labeled as Triple P. Triple P stands for Positive Parenting Program, and therefore the 3 Ps. It's a evidence-based, well-tested international model to prevent and treat behavioral and emotional issues by providing parents with tools and abilities to address their children's needs. We have supported providers in becoming trained in Triple P interventions. We have funded an initial cohort of 80 providers to complete the trainings they will complete their training in April of this year of 21. I'm sorry, they completed their training in 21. They began in April of last year. We began an additional 40 provider cohort for this training in September. Important to note that we are reimbursing the providers not only for the time that they are spending delivering this service, but we are reimbursing them for their time during training. So again, removing that barrier so that more providers and more service practitioners can be trained in this evidence-based model to increase the capacity in the state. Similarly, and you've heard me, I believe, talk before about our work around TFCBT, which stands for Trauma-Focused Cognitive Behavioral Therapy. This was, again, one of our approaches in Family First, and one of the things that we wanted to invest in to increase the capacity in the state. Very happy to say that we have completed an initial group of trainers through the work of the Children's Cabinet as a convening body of 165 TFCBT therapists. We implemented that no-cost training for them and again provided reimbursement for their time spent in training and clinical consultation. Last year, we added an additional 40 clinician cohort, and we also implemented a fidelity tracking system with existing providers. Some of you may remember that some years ago, the state similarly invested in training and building up the capacity of TFCBT. And over the years, the number of TFCBT therapists began to wane. What we heard from the therapist was there was no way to sustain this higher level of intervention going forward. So one of the things we learned from that and have implemented now is a higher main care reimbursement rate for TFCBT. So once a trainer is nationally certified, they're then eligible for this higher reimbursement rate so that we can sustain this investment going forward and retain these providers to continue to provide this higher level of therapy for youth in the state. From a residential treatment perspective, I'm very happy to say and give you an update from what we talked about last spring, where we were beginning to work on an updated Section 97, also known as PNMI, also sometimes called Children's Behavioral Health, for those residential programs. We were able to work with our colleagues in Main Care in order to update the rules and the rates related to these PNMIs. It is the first time in approximately 10 years that the rates were studied and the new rates put into effect. The new rates are significantly higher, 45 to 75% higher. And at the same time, those new rates reflect a higher level of expectation of performance and outcomes. Very specifically, this includes the fact that these new rates conform to the new federal guidelines related to what is sometimes called a QRTP, a Qualified Residential Treatment Program. These new, this higher level of service and expectation of service delivery, we believe will increase quality, which ultimately will decrease the amount of time that youth are staying in a residential program before they return home or to a different type of family-based care. One of the pieces I'd like to say very clearly is my thanks and sincere appreciation to all of our state's children's residential providers. They all voluntarily agreed to meet the new higher levels of care embedded with a QRTP. They're all moving towards or have achieved those new levels. My compliments to them, my thanks to them, and I believe our entire state, our children, our families, and others will benefit from this very significantly in the long run. Somewhat related to that is another acronym, which you may, I know, have heard us talk about before, which is the PRTF, which is the Psychiatric Residential Treatment Facility. We currently, as you may know, have no PRTFs in the state of Maine. So for children who need this higher level of care, which is beyond the level of a traditional children's residential or a PNMI setting, we currently have no options for those youth in the state of Maine. It's something that we identified in 2019 as needing to be addressed in order to fully implement a true continuum of care of services for youth and families in the state. We do have a Section 107 rate for PRTFs in the state. We had attempted in 2019 and 2020 and really into 21 to identify and work with two different providers to stand up a PRTF in the state. And their analysis and feedback told us what we were concerned about, which is that the current rate did not support them to be able to sustain that service in the long run. This was further supported by the fact that the new PNMI rates that I just spoke to you about, in some cases, those rates for a lower level of service, the rates are higher than the established Section 107 rate for a PRTF, which is a higher level of service for youth. As a result of that, we paused our further work on the PRTF strategy, and now with the implementation of the updated PNMI rates and rules, we are now pivoting back to the PRTF strategy. We're working collaboratively with our friends and colleagues in Main Care to review and update that rule and rate structure. And then once that is in place, we hope to be able to work with providers to stand up one or more PRTFs in the state of Maine. I know several of you have talked about, and some of you have heard bills related to crisis care in the state of Maine, and I wanted to give you two updates as it relates to crisis care from the perspective of youth. The first one is a pilot project that we initiated, again with support from fund dollars through the Children's Cabinet from Fund for Healthy Maine. In 2019, we implemented a pilot program involving crisis aftercare services in Aroostook County. And these aftercare services are really intended to reduce the need for children and families to access emergency departments and instead allow families to safely maintain their children at home. We piloted it in Aroostook County. We were very pleased with the results that I'll share with you in a moment. And as a result of that evaluation, we are now implementing that program statewide using some federal relief dollars that have come to the state of Maine. Let me give you a few examples of what we mean by success in this pilot. One of our performance indicators for the pilot was our goal was for 75% of the children who received this service to be able to remain at home and not require emergency department or inpatient psychiatric care while receiving that pilot service. Happy to say our goal was 75%. We actually achieved it in 87% the cases. So 87% of the youth and families that were receiving this service did not need that ED or inpatient level of care as a result of the service. We also had a goal of 90% of the children waiting for discharge from the emergency department to receive their initial contact with this pilot service within a 10-hour period. We actually achieved that, or the pilot actually achieved it in 91% of the cases. And last, possibly most important, we had a target of 80% of the children who were approved for a higher level of care, say a residential level of care or an inpatient hospital care, to be able to be successfully maintained in their home while they were waiting for that spot or bed to open up. So our goal was 80% of the time, we wanted them to be safely maintained at home, where our results were 100%. So in 100% of the cases, they were able to be safely maintained in their home while they were waiting for that higher level of care. As a result of these success factors, that is why we decided to move this program on a statewide basis using federal relief funds. The second point on this slide is about our overall crisis system of care. Happy to say that last year the department was awarded a federal grant to improve the crisis system of care for both adult and children's systems. We're working collaboratively with our partners in OBH, Office of Behavioral Health, and Maine Care in order to implement that grant, and looking forward to making progress in both the adult and children's side on crisis care. One other piece on crisis care. The legislature passed, you may remember, in the first regular session, LD 118, which this committee considered and passed, and eventually was passed by the legislature. You may remember that this required data collection and reporting on the utilization of emergency departments for youth with mental or behavioral health needs. After that law was passed, OCFS began collaborating with stakeholders on the implementation of LD 118. We had a number of monthly meetings with stakeholders, including our hospitals, providers, and others, in order to come up with a consistent set of definitions and a way of collecting this data. We test ran that process in the months of December and January for data in the months of November and December. So we have tested it out for 2 months. I believe we've worked out the kinks, and beginning in the month of February, we'll be collecting that data for all hospitals so that we can have a full set of comprehensive data to be able to report back to this committee in the future. My thanks to those providers, hospitals, and community stakeholders who came together to work on this project, and we look forward to sharing that with you in the coming months and years. Substance use disorder. Last week, in advance of a work session that you held on a bill, we provided you with information about progress that we've made on youth substance disorder. The next 2 slides summarize that work. I do want to give a special thank you to the John T. Gorman Foundation, who funded a 1-year position for us to kickstart this work. Very pleased about the progress that we were able to make. We have now been able to continue that position so that we can continue our progress moving forward on youth substance use. This slide on 28, as well as this slide on 29, provide you with some additional information on projects as well as the work that has been completed. I will point out that I'm quite pleased to say that in 21, despite the challenges of the pandemic, we were able to add a new intensive outpatient provider in the state, 2 new outpatient programs in total, and 1 new residential program was added in the state. And that's despite the challenges of the pandemic. So my thanks again to the team working on that effort. Workforce is something I'd like to spend just a couple of minutes speaking towards. First and foremost, I want to recognize the challenges that our children's behavioral health and behavioral health in general has had as it relates to workforce. We know, appreciate, and understand those significant challenges that have happened within the workforce area of behavioral health. This slide details for you some of the ways that we have been working to bolster the workforce in the state. Whether it be through behavioral health professional recruitment, that has resulted in 336 individuals enrolled in no-cost behavioral health provider training through us. 87 of them have become certified already. Happy to say also with the FMAP program facilitated by the American Rescue Plan, we're able to invest matching funds to provide assistance to the workforce. That work is largely being led by our colleagues in the Office of Aging and Disability Services, but with support from the other offices within DHHS as well. OCFS in particular, using those FMAP dollars, will be implementing, we have received CMS approval to implement the use of those dollars to implement a high fidelity wraparound project. Some of you may remember the state about 10 years ago had high fidelity wraparound. It was generally seen as fairly successful. It was not continued during the intervening period. Happy to say that we're able to use these dollars to start that project up, learn from the experiences of that previous project, embed current evidence-based practices in it, and move that project forward. And you can also see how we're engaging with stakeholders as it relates to workforce as well. And last, you heard last week in a bill work session around our progress around the Early Childhood Consultation Project, sometimes called ECCP. And this summarizes that. I know we talked about this at greater length during your work session, so I won't repeat that information here, but it is a project that we're quite proud of, very pleased with the progress that we've made with ECCP, and look forward to continuing those efforts going forward. And Representative Meyer, I'll stop there to see if you would like to take questions on CBHS before we talk about childcare.
Certainly. Questions from the committee on children's behavioral health? Seeing none, actually, Representative Craven.
Thank you. Thank you for the presentation and all of the work that you're doing. I was on a webinar 2 nights ago with Maine Health, and you know, the crisis seems endless, I guess, in that their beds are full and there is just no end, I guess, to the backup and the lack of services. And so I love how you know, enthusiastic and all of your presentations, but wonder if you could talk a little bit about what's going on on the ground in you know, while parents and others are waiting for their child to have adequate services.
Representative Craven, thank you for your question. I would first off by saying my enthusiasm for the work that we are doing and moving forward does not necessarily mean that we have solved all the problems. We clearly have not, and I want to be clear about that. In 2019, when I first met with this committee, I gave you my impression of Maine's children's behavioral health system, saying that in many respects we were embarking on a process of rebuilding the children's behavioral health service continuum versus improving it. That work certainly has become even more complicated and complex due to the pandemic. But as you can tell from my presentation, it hasn't stopped us from continuing to try to move some of these projects forward. But we're not there yet. And what we are certainly seeing and continuing to see is youth coming into and sometimes staying in an emergency department setting for too long, longer than any of us would like to see a youth waiting for those services. The initial data that we are collecting through the LD 118, if I can use that term, process, is indicating very clearly to us that it is both a challenge for youth waiting for a residential placement in many cases, but also for an inpatient hospital bed. So we know that it is a challenge on both of those fronts. OCFS tends to get much more involved when there is a wait for a residential placement bed versus an inpatient bed. The inpatient work is largely usually done through the hospital network themselves. We certainly cooperate, support, and help with that. But in many cases, our work primarily focuses on the youth who are waiting for a residential placement bed. It is one of the ways that I think, as we fully implement statewide some of our aftercare work, that we're going to be able to relieve some of that pressure, if you will, on some of these programs. Because if we can successfully enable youth to be able to be maintained in their own homes while they're waiting for one of those inpatient beds or a residential treatment bed, then that's going to benefit, everyone. But again, we have just now embarked on expanding that pilot and hope to see some of the results. So that's a near-term solution. Longer term, I think we're going to have to continue to work on rebuilding our entire service continuum and array. That would certainly include the stand-up of a psychiatric residential treatment facility, but it also must include a rebuilding and increasing availability and access for home and community treatment options as well. That's why the projects such as Triple P, TFCBT, and some of these others are so vitally important. Will it happen overnight? No. The system was not deconstructed overnight, if I can use that term. We're not going to be able to rebuild it. Honestly, if it had not been for the pandemic, I think we would have been further along that process. But we continue to make good progress, and we'll continue to drive towards that direction. And hopefully you can see through my presentation some examples of how we're trying to bolster home and community treatment options, bolstering crisis, and then bolstering the very top end of our pyramid around residential programming and eventually a PRTF in the state.
Thank you.
Senator Moore.
Yes, thank you, Madam Chair. Dr. Landry, I'm really interested in that trauma-focused cognitive behavioral therapy training. What is the length of the training, and is it in person? Is it virtual? How is that? How are they able to take the training?
Yeah, until the pandemic came along, it was almost always in person. But the trainers of TFCBT recognized that wasn't going to work. So for our project, it's been all virtual. So the training is completely virtual. It is not a short process. I want to be very clear about that. There's initial training, which is done virtually, and then there is a 1-year period of clinical consultation where the therapists are receiving monthly clinical consultation with the providers of this or the trainers of this service to ensure that they're able to deliver that program with fidelity and get the outcomes that we all want. It's not a short process, but I'm happy to say that we started back in 2020. We're able now to have 165 more of them in the state, with more on the way. Eventually, we want to continue to bolster that. We want to continue to support that, which is why the sustainability aspect of the main care rate, I think, is so critical. Now, for you in particular, knowing your districts, I will tell you, we tend to have more of these in the more urban parts of the state versus the rural parts of the state. So that becomes part of our work with our system of care grant, is trying to encourage more of those services in some of our less served parts of the state, which tend to be, in many cases, our more rural areas.
Well, I love the idea that we actually will, provide them a reimbursement for their time spent in the training. I think that's huge because so many people have to work, and there's just no way they can take time off to go for training like that. Now,
it was one of the pieces, if I may add, it was one of the pieces at the very beginning that my staff were adamant about in working in going through this approval process for this project. They were absolutely adamant. We had to pay for that if we were going to get the numbers that we wanted to begin to go through the training.
Now, how long is the initial virtual class?
I can get you the details on that. It's a number of hours. For 20 hours is sticking in my head, but I'll get you the details on the number of the initial training that's needed.
Be good for us to get the word out. That's what I was thinking. Thank you.
You bet.
Representative Perry.
Thank you. I'm really very pleased with the results of the pilot project, which seems to also help really the cost of behavioral health on the healthcare system itself. And I'm looking at how would you and what timing does it look like to expand this statewide, and what added cost are you looking at?
Thank you, Representative Perry. I will get you the exact cost of this. I don't have that off the top of my head, but we'll get you the exact cost of what it is costing for us to go statewide with this project. Again, we're using some of our federal relief dollars to go statewide at this point. I'll get you those exact dollars. We are implementing statewide at this point. I know in different counties, they're in different stages of where they are on implementation, and we can provide you with more details for you and the members of the committee so that you know who specifically and which entity specifically. And this is on a contract basis, so I want to be clear, we're not doing this using OCFS staff. We're contracting for this with community-based organizations, and that way you'll know exactly which ones are serving your parts of the state.
Seeing no other questions on children's behavioral health, we would ask you move to early childhood education.
Fantastic. One of the things that obviously has been a significant discussion and question during the pandemic, but pre-pandemic as well, has to do with childcare and early childhood education. I wanted to share with you the significant amounts of federal relief dollars that have come to the state before I talk to you and share with you how those relief dollars are being utilized. On a typical year, what we would call a base year, you can see that our CCDBG, our Child Care Development Block Grant funds, so this would be both federal as well as the state match or the state MOE, is about $35 million. The primary use of these funds is for child care subsidies for families that qualify, although there are some funds available for training, technical assistance, and quality improvement. Beginning with the CARES Act and CRF, you can see we received in the state of Maine about $19.3 million. CRSA provided us an additional $30.5 million specific for childcare. And as you can see, ARPA is the big one on this one. ARPA has provided us $122 million related to childcare. This, as you can tell, is a massive investment in childcare, and it came at a much needed time. And I think you have heard that from your constituents as well as other colleagues. To give you some idea of that, I'd like to just share with you a little bit about how these dollars have been implemented in some of our initiatives related to these funding streams. For the CARES Act, $10 million were made available to child care providers through stipends and grants, with most of the rest of those dollars being available for child care subsidy for essential workers, as it was called then, during the early months of the pandemic. CRSA money, or CRSA funds, again, were provided through grants to child care providers over, I believe approximately $15 million, or roughly half of the CRSA funds were paid out to child care providers. We also were able to support our child care providers using CRSA funds by changing the subsidy amounts to enrollment-based reimbursement versus attendance-based reimbursement. We waived parent fees, and I will tell you that that is one of the biggest ways that we have heard support from our families, because we waived the parent copay and have continued to waive the parent copay to assist them during the pandemic. We've also improved our Childcare Choices website so that families can locate childcare more easily and effectively, and provided professional development for our childcare staff. Regarding the big amount of money here, the ARPA funds of $122 million, our child care plan for Maine, which we released in May of last year and then updated in September of last year, focuses on 3 categories. You're probably familiar with these because we've talked about them before, and those rely on or focus on access, quality, and workforce. The biggest portion of the $122 million is $73 million that are going to stabilization grants. And this includes a $200 per direct child care worker stipend that has been in effect. And I'll share more details about that with you in a moment. We also were able to use $18 million of this $122 million to cover a projected Child Care Development Fund shortfall to ensure that there is no waiting list for eligible families to access subsidy. We've been able to continue to pay providers based on enrollment versus attendance. $6.5 million is being utilized to waive parent fees for families to continue that process. Although the federal government did inform us that we had to change from all families to those that were at or below 60% of state median income for the second year of that program. We're also providing stipends to newly licensed family child care programs, waiving child care licensing fees for 2 years so we can support new and existing providers, as well as a number of other projects that are outlined in our child care plan for Maine document that's posted on our website. I want to give just a few more details about our stabilization funding distribution in Maine. So this is $73 million. All of it is going out to providers or directly through the providers to our child care workforce. Happy to say that Maine was one of the first states to begin distributing this funding to providers and workers. We began distributing these dollars in October. There are still some states in the country who have yet to begin to distribute these dollars. And I know some of you who are members of the Children's Cabinet, or I'm sorry, the Children's Caucus, heard from some of those providers and those advocates in this week's meeting where they talked about how important these stabilization grants have been to them. Over 1,300 of our providers have received these grants. That's approximately 90% of all of our providers have applied and received these grants. Over 6,600 direct child care workers have received those $200 a month stipends or bonuses. And so far, through the first 4 months, we have distributed over $22 million through January to our providers and to our direct care workers. I will point out these are some additional investments that have been made either through CRF, the Payroll Protection Program, and I want to take a moment to tell you where we stand on LD 1733. There is a component of LD 1733 that provided $10 million to fund grants for what we sometimes call bricks and mortar investments to enable programs to start new childcare facilities or programs or to expand their existing facility and program. We are moving through that approval process. We are working with communities in order to develop the application process for that. And we are looking forward to hopefully beginning to roll those grants and the application process out late in the first quarter of this year. Excuse me. One of the bills that this committee passed and we are working on implementation of is, I believe the number was LD 1712, which involved Help Me Grow and First for Me. The summary of those two components of LD 1712 are shown on this slide. Happy to tell you that earlier this month, a Help Me Grow kickoff event was widely attended by many advocates, providers, and others. We have also hired our Help Me Grow program manager to implement the program, and we're currently finalizing the contract with the Help Me Grow national organization in order to provide us with technical and training assistance. On the First for Me side, all of the First for Me positions have now been posted. and we have plans to work with colleagues at Educare to leverage their experience with technical assistance and expertise as we move towards implementing these programs. And we look forward to sharing with you more information on that in the near future. And with that, I'd be happy to take any questions that you may have about childcare or any of the other areas that we've talked about today.
Additional questions from the committee? I see Senator Moore's hand up.
Thank you, Madam Chair. Dr. Landry, with these ARPA funds, what is how quickly do they have to be spent?
It depends. There are two components of the ARPA funds. The first one is the stabilization grants, the $73 million. Those have to be, use the right word here, those have to be dedicated or committed by the end of September of this year. So those funds, we do have a run out period of type of sorts in order to fully expend all of the dollars. But those 73 million have to be fully accounted for as far as where the dollars are going by the end of September. There's another component of roughly $50 million that are in what the ARP bill calls discretionary funds. Those funds have an additional year that we have to be able to utilize those dollars. So that is in part why our child care plan for Maine is differentiated between stabilization and discretionary, because of the length of time that's available to expend those dollars.
Great, thank you.
Dr. Landry, what are we doing with regard to attracting and retaining quality childcare providers? Sort of taking a cue from the healthcare sector and knowing how important it is to have a career ladder in order to attract folks into the profession. Are we doing anything similar in the childcare sector?
I think we're doing a few things. First and foremost, in the very near term, of course, those $200 monthly stipends we're hearing from the field is helping tremendously to attract and retain the staff in those programs. So that's a very, very much a near-term aspect. We're also, though, working on some longer-term aspects as well, such as the career registry and incentivizing individuals to be on that registry and being able to reward them in the future for moving up that registry with additional education and training. I also anticipate from a provider or a facility perspective, not the worker, but the provider perspective, I think the new infrastructure grants are going to be a significant help in building new or expanding existing child care programs. I will tell you initially, because of the time it takes to build a brand new bricks and mortar facility, I think the first year, if you will, of those infrastructure grants are primarily going to be focused a lot on our family child care providers, because those are the ones that are going to be able to more quickly implement expansions of their programs, whereas some of the ground up bricks and mortar programs are probably going to come in the second year, because it just takes longer to develop and begin work on those pieces. So we're trying to do this from both perspectives: the worker component as well as the provider component. The last thing that I will say is we are working very concertedly with our community colleges in order to continue and bolster their efforts, because that is where a lot of our staff are initially trained or in the certificate programs for their CDAs, Child Development Associate degrees, and similar. And so we continue to work very strategically and with all of our community colleges to try to encourage more of those staff to come in, including scholarship programs that we do in partnership with AEYC, which is the TEACH scholarship that you may be familiar with. And then the last thing I'll say is, I believe you're aware there were 2 holdover bills related to workforce and workforce supports. And we continue to, obviously engage and work with the legislature on those 2 holdover bills.
Thank you. Seeing no other questions from the committee, we want to thank you for being here today for a wide-ranging, comprehensive report to us We appreciate your work on that and your staff's work on that. Clearly, it involved quite a bit, and we are grateful for that.
Thank you very much. My thanks to the committee, and we will make sure and get back to you with the questions that I was unable to answer during the call today.
Thank you. And I will turn to our analyst, Anna Broom, and ask her if there is anything left on our agenda to take care of today. She is saying no. I would entertain a motion then to adjourn.
So moved.
I'll second that.
Second.
All in favor? We will see you tomorrow at 10 o'clock. Thank you for your work today.